and welcome to the first International Symposium on COVID-19 Long Hauler Syndrome, also known as the post-acute sequelae of the SARS-CoV-2 infection, or PASC. This is also called long COVID. This conference is sponsored by the State University of New York, Downstate Health Sciences University, located in Brooklyn. This is one of the largest public institutions in the country with 64 campuses, and one of them is in Brooklyn. Also sponsored by the Black Health Trust. The Black Health Trust was founded by Dr. Randall Maxey in response to the COVID-19 pandemic to bring trustful information given by trustful experts around the country to people of color on a weekly basis, and has done so since the pandemic up to date. The Brooklyn Health Disparities Center is dedicated to elimination of health disparities in Brooklyn, and is NIH funded for that reason. We are also very thankful to our co-sponsors, the New York chapter of the American College of Physicians, NYACP, and the MBI Health Services LLC, located in Washington, DC. The New York chapter of the American College of Physicians is the largest of the American College of Physicians chapters, with more than 12,000 members. MBI Health Services is one of the largest mental health providers in the Washington, DC area. Now, the concept of this conference originated from one of the meetings of the Black Health Trust on a Sunday. It was evident that more than 180 million people have had COVID-19 infections, and over 3 million have died. So more have survived. But it has come to our attention that more than 30% of these patients who have recovered continue to have symptoms that we don't know where it is coming from. And that is the reason for this conference. So this conference is designed to uncover why some patients who have recovered from COVID-19 continue to have symptoms, and those symptoms could easily be disabling and could have complications as well. I would like to thank the planning committee, myself included, but more importantly, Dr. Randall Maxey, MD, PhD. He's the founder and CEO, Chief Executive Officer of the Black Health Trust. Dr. Maxey has been instrumental in bringing this group of experts around the country on a weekly basis to discuss issues around COVID-19 and to bring trustworthy information to people of color. Dr. Kitao Demisi, MD, PhD, is Professor and Dean of the School of Public Health at the State University of New York, Downstate Health Sciences University in Brooklyn. Dr. Demisi has an illustrious career in public health and is leading the contact tracing for all infections around the SUNY campuses. This is a tremendous job of trying to see who had what and why did they get infection of COVID-19. It's a marvelous job done by him. We have Dr. Barbara Neighbor-Stevens, MD, MBA, and the fellow of the American Academy of Pediatricians. She is the Senior Medical Director with Molina Healthcare. And then Dr. Ivan C.A. Walks, MD. Dr. Walks also has an illustrious career in public health, but he's a psychiatrist by trade. He's currently the CEO of Ivan Walks and Associates. I'd like to thank you very much, planning committee members, for putting this wonderful symposium together. To start, I would like to make some few housekeeping remarks. First, please use the chat box to ask questions. We will be going through the program speaker by speaker, and at the end of each session, the moderator of the session will take questions from the chat box. Obviously, there will be more questions than we can answer in this short period. But we would get back to you if we haven't answered your question in the chat box. So please use the chat box. Second one is that the program will be posted in the chat box. So if you wanted to follow the program, just click on the links and then you can get the entire program and you can follow exactly what the speakers are saying as we move along. And number three, we want to be on time. So we ask that the speakers stick to the time. Each of the speakers has 15 minutes. Again, this is a compressed symposium. We want to be able to deliver as much as possible in that short period of time and be able to have time for the questions and answer sessions. So speakers, please stick to the time interval. And I ask the moderators to do the same. Please remind the speakers to stick with the time table. So those are the opening remarks from me. I think that this is going to grow as we get to slow down on the actual infections on the pandemic. More and more, we are going to be seeing complaints and diseases associated with previous COVID-19 infections. And hopefully this conference will uncover those issues, generate a lot of thinking, generate a lot of networking so that people can work together academically and come up with solutions to these problems. And hopefully we can have another conference in the subsequent years to bring more information. At the end of this conference, we also hope that you would follow us on the internet. We plan to publish the proceedings of this meeting, either in journal format or as a book. So stay tuned to have actually print copies of this symposium for your references. Now it's time for me to invite one of the opening remarks presenters, Dr. Wayne Riley, MD, MPH, MD, and the Master of American College of Physicians. He's the current president of the State University of New York, Downstate Health Sciences University in Brooklyn. Dr. Riley is so well accomplished. He's a health policy expert, one of the greatest in our country right now in terms of managing academic medical centers. He was the prior president of the Meharry College of Medicine in Nashville, Tennessee. Before that, he was president of the American College of Physicians and many more. His undergrad education was at Yale University in New Haven, Connecticut. His medical school education was in Morehouse in Atlanta. Following that, he went to Baylor College of Medicine for his internal medicine residency. And after that, his career just took off. He became Associate Dean for Education and later became the president of Meharry College and subsequent accomplishments. His bio is included in the bio section of the program. It's a long bio. Again, our attempt is to highlight the careers and let you get to the very details of the bios in the actual program itself. So please join me in welcoming Dr. Riley to give opening remarks to this conference.
Hello, it's my pleasure to welcome you to this very important international symposium focused on learning lessons about the COVID-19 pandemic. My name is Dr. Wayne Riley. I have the honor of a lifetime to serve as the president of Downstate Health Sciences University, where I also hold professorships in internal medicine and health policy and management. Over the last 18 months, the world has been grappling with this once-in-a-lifetime pandemic that has left many communities devastated with unspeakable death and disability. This conference, this symposium, joined by many colleagues from around the world, will be very helpful to understanding better how we can prepare for the next pandemic and how we can do better in terms of patient care for those who've been afflicted with COVID. So it's my hope that your participation will be fruitful. It will establish new connections and that you will go away from this conference fortified to do even better in your respective home country or your respective health system or your office, clinic, or hospital in the taking care of COVID patients and improving the health of all people.
Okay, thank you, Dr. Riley. He wasn't able to make it, but we thank him for making the video and making the presence. The next person I would like to invite to give opening remarks is Dr. Leon McDougall. Dr. McDougall is the current president of the National Medical Association, which represents a large group of the doctors in the country, mostly of color. Dr. McDougall started his career at the Toledo, the undergraduate education at the Toledo University. Following that, he went to the Ohio State University for medical school, and then residency at the Naval Hospital in California. Following that, he had an MPH in the University of Michigan, and then following that, an illustrious career, which was just remarkable and currently still remarkable. He rose to professor of family medicine and currently the dean for the associate dean for diversity and inclusion at the Ohio State University Medical School. Please join me in welcoming Dr. McDougall to present opening remarks.
Good morning. I'd like to extend greetings on behalf of the National Medical Association as its 121st president, established in 1895. I'd like to commend SUNY Downstate Health Sciences University, the Black Health Trust, and Brooklyn Health Disparities Center for convening this timely first international symposium on COVID-19 long haulers syndrome. Most often, COVID-19 variants, immunization rates, and death totals are the lead stories in United States media, without much focus on morbidity, thus highlighting the need for this international symposium to speak to the full dimensions of COVID-19 morbidity during a pandemic. I look forward to learning from the experts presenting today, and thank you so much for your participation.
Thank you very much, Dr. McDougall. The first session is now open, and the moderator is going to be Dr. Randall Maxey. I'd like to say a few words about Dr. Maxey. He's a great friend, great colleague, one of the nation's top physicians, whose interest is just basically making sure that the community is well served. He's done that for over 40 years. He was the past president and chairman of the board of the National Medical Association, and founder and CEO of the current Black Health Trust, which was founded to provide credible health information regarding health disparities in COVID-19, provided by a panel of nationally recognized physician experts in over 20 specialties. I would like to welcome Dr. Maxey to moderate the first session.
Thank you, Dr. Salafu, and thank you for being one of the key presenters at the Black Health Trust and one of the best academicians in America. And thank you for putting this symposium together. Let's get right to our first introduction. This is the symposium concerning post-acute COVID syndrome. And our first speaker is Dr. Ketal Demisi, MD, PhD, who is the Dean of the School of Public Health at State University of New York, Downstate Medical Center, Health Sciences University. Dr. Demisi previously served as an Associate Dean for Faculty Affairs at Rutgers University School of Public Health. He is also nationally recognized as an academic and public health leader. You'll be able to see in the chat box his full information. Most of our speakers will take up the next half hour just introducing them. So I'd like to introduce, for your learning and your pleasure, Dr. Ketal Demisi.
So if you can see this slide, it tells you that currently there are about 70 million confirmed cases of COVID-19 globally, and about 4 million have died out of those 117 million cases as reported to WHO. And the dark blue shading countries represent the highest incidence, greater than 5 million cases. And these countries include the United States, Brazil, the Russian Federation, India, France, and Turkey. Countries that are shaded in blue represent between 500,000 and 5 million. And these countries include Mexico, Colombia, Peru, Argentina, and most European countries in the Middle East, Iran, Iraq, and from Africa, South Africa, and Sweden. As you know, as you can see, the numbers are very low in Africa and Australia, but these numbers are likely to be an underestimate, as you will see later. And this figure actually gives you the coronavirus burden by WHO region and how it changed within the last 1 week, you can see that there is a continuous decreasing of coronavirus over the past week, with over 2.5 million new weekly cases and over 64,000 deaths, showing that a 6% and a 12% decrease in incidence and mortality from the previous week, which is a very good welcome. You can see here that most of the decreases happened in Southeast Asia and Europe, but on the other hand, you see a dramatic increase in incidence and mortality in Africa, close by 40% of incidence and mortality. So the epidemic is not really decreasing evenly in all countries. And I will try to show you the impact of this pandemic in some population subgroups, because the impact has not been really even among population. This is a slide from Santiago, Chile. And as you can see, when the social class decreases, the burden of disease of COVID-19 in both morbidity and mortality increases. So it affects people from lower socioeconomic status, and clearly people of color among African Americans are largely affected by this disease in the United States, and the rate is about twice among Latinx and African Americans compared to whites, and also compared to Asians. But that twice higher rate actually masks significant racial disparities when you go to by age group, and the substrata of this age group shows you actually the rate of mortality is about 7-fold in Latinx and in African Americans in younger age groups between 0-24, 25-34, up to 65-74. After that, because it is a larger population that we have, that will be around two times. That's why you see the overall effect of 2, but the effect is really dramatic by age group when you see how it affected the minority population. In pregnant women also, the risk of all-cause mortality, ICU admission, and preterm birth is increased, and the developing fetus is affected by stillbirth, and when they are born, the neonatal mortality rate and admission to NICU is dramatically increased too. So because of the decrease in all these things, are we saying that now COVID-19 is going to disappear? The answer is probably no. It may actually continue to exist in some form, and instead of probably becoming a pandemic, it may turn out to be an endemic. As you can see on this slide, there are many variants of concern. Alpha, which was developed in the UK, which came from the UK. Beta is South African, Gamma is Brazil, and Delta is now the more recent one spreading in the United States from India. And we have also a lot of variants of interest that we are following. And all these variants are likely to cause a lot of problems in addition to the low vaccination rate that you see in many parts of the world. If you look at this picture, you can clearly see that the vaccination rate is above 50% and 60%, above 50% in developed countries like Canada, United Kingdom, Israel, Italy, US, and Germany, France. But when you go to the rest of the world, you see the vaccination rate really being very low. And this slide also shows you clearly the distribution of the vaccination rate. And as you can clearly see here, the United States is mostly highly vaccinated, but the vaccination rate in other parts of the countries, especially in Africa, is much, much lower. So that is a major concern. Even within the United States, if you see the city of New York, you can clearly see that the vaccination rate is close to 70% in Manhattan primarily, but when you go to Brooklyn, Bronx, the Bronx, and some parts of Queens, then the vaccination rate is much lower. Although there is a lot of interest, in willingness to take the vaccine, there is some kind of vaccine hesitancy in some parts of our world and also among some population segments. And if you look at also the daily infection global projections, yes, it is really decreasing over time, but you see as the cold season comes, the chance that some of the viruses that are really occurring in some parts of the country here and other parts are also likely to have a little higher rate of infection. So it is very difficult to conclude that this virus is going to really disappear and we don't have to worry about the virus, because it's not going to be an easy solution. So in light of the data presented, what is the implication of COVID for PASC, or post-acute sequelae of SARS-CoV-2 infection? And the evidence is every time increasing that a considerable proportion of patients will continue to exhibit persistent symptoms and or organ dysfunction beyond 30 days, which is about 4.5 weeks after the initial development of COVID-19 infection. And there is no consensus on the terminology or nomenclature about this condition, but variably it was given different names. Some call it post-acute COVID-19 syndrome, some long COVID, and some post-acute sequelae of COVID, or PASC. We may be using this terminology mostly from here on. And the patients that who are suffering the condition are referred mostly as long haulers. So as you can see, the long haulers present with a lot of symptomatology. It affects different organs. The most common symptoms are fatigue, headache, memory loss, anosmia, all kind of things that you see on the slide is the symptomatology of this condition. Now, IgG antibodies was found to be an important predictor. Persistence of IgG antibodies was found to be persistent predictor of the PASC syndrome. And PASC days, development of PASC, is the risk factors, or the development of PASC is dependent on the presentation of the patients during their initial index COVID presentation. If they are hospitalized during the COVID presentation, almost 50% of them develop actually PASC. And if they are symptomatic, close to 30%. And if they are asymptomatic, close to 23% of them actually develop PASC. And this is very important because also PASC days of PASC is mostly common among people who were hospitalized for their COVID symptoms. And these are the risk factors for the days of the PASC deaths. Now, what is the COVID implications for PASC? And if you remember, this slide will be crucial in really estimating the number of PASC patients that we're having now and what we're going to encounter in the future. So if we have now globally, we have now totally confirmed global cases of about 178 million, which means the literature is very clear from many studies that for each case of COVID, there are about 5 undiagnosed COVID cases. So the undiagnosed or mild COVID cases is 5 times 178 million, which gives you about 894 million, close to a billion, which makes the total cases of COVID about 1 billion. And if you look at the hospitalization rate of COVID, it is about 4% from the literature, and the hospitalized cases among confirmed cases, 4% of the total COVID cases will be about 7 million people. And if we expect 50% of them develop PASC, then from that populations, we will get about 3.5 million PASC patients. And among symptomatic, as I said, it is about 30%, and 30% of 171 million by subtracting those people who are hospitalized. The remaining is 171 million, and 30% of that is about 51 million. And from the asymptomatic, as we said in the table, they bring about 20% of PASC cases. So 20% of 894 million will give you about 178 million. So the total current PASC case, about 233 million. And as the disease is going to continue, we're going to have more PASC patients. And as I said previously, it affects minority population and lower social class population, and chances that patients are hospitalized when they are in the lower socioeconomic status, and also people of color, which tilts even the number of PASC patients to minority patients. And you can imagine the economic burden and also the healthcare burden associated with PASC with this many patients that we're going to have. I conclude my talk here. Thank you.
Well, thank you. We're going to appreciate you for giving that stellar talk, and we will ask you to stick around for the question session, which will be our full panel. The next person I'd like to introduce is a good friend of mine, Dr. George Benjamin, MD. He's well known in health policy leader. He's been a practitioner and administrator. He currently serves as the executive director of the American Public Health Association, the nation's oldest and largest organization of public health. He's been with us on the Black Health Trust and is a noted and trusted expert in public health issues, and especially COVID-19 and long haul syndrome. Dr. Benjamin, would you please present to us?
Well, thank you very much. And that was an amazing presentation on the global front. And I'm going to focus a little bit on the U.S. situation. I don't certainly have any financial disclosures to declare. And you heard that we obviously have an amazing and tragic global outbreak, but even in the United States, we have over 33 million cases with over 600,000 deaths in our country. Over the last year, we have seen the epidemiology of this disease develop. We certainly knew that Ru was greater than 2, but it's clearly a very infectious disease, and many of the variants are now becoming more infectious each and every day. Originally, we were not sure that we had asymptomatic transmission, but it occurs. And we discovered that it's as much as 40% of cases were able to be transmitted asymptomatically. And just like in China in the early part of the outbreak, and I think this has persisted around the world, about 80% of these cases are people who have relatively mild symptoms to being asymptomatic, with about 20% having severe cases, and as many 5% of the total cases ultimately requiring to be in an intensive care unit. We know this disease is more than a pneumonitis, that it not only invades the lungs, but it invades other tissues, and that it evokes either directly or indirectly a range of autoimmune phenomena that have resulted in strokes and clots and a range of immune dysfunction, the multisystemic immune function that a small number of kids get, the myocarditis and pericarditis that we're seeing directly from the disease is profound. And so this is, one should think of this as a total body disease and not just a focused pneumonitis. And of course, we now know that it has a chronic syndrome, which has been called long COVID, or as also the long haul syndrome, amongst other nomenclatures. And I think one of the important things will be for us to come to some agreement about what the definition of this disease actually is. There's some NIH studies trying to make sure we understand the case definition, but I think the simplest thing would be for us to come up with a common name so we all know what we're talking about. The disease itself, while we really don't know the fatality rate overall, because we really don't know the denominator because of the number of asymptomatic cases that we've had, but conceptually it's somewhere between 1.5 and 3.5 overall. We also know that the all-cause mortality from this disease is really a bigger issue, because it's not just what's happened directly from COVID, but because we've been sequestered and because healthcare has not been provided to many communities in the normal way, the all-cause mortality from this event is much higher and ultimately is a bigger issue to society than just the direct case fatality rate from COVID-19 and SARS-CoV-2 as a virus. We obviously know that these disparities by race and ethnicity are prevalent. These emerged in the United States as they did in other nations that have diverse societies fairly early. And with the emergence of these viral strains, right now everyone's concerned about Alpha through Delta. Delta is emerging as a predominant strain in the United States. I just remind us all that while we're worried about Delta, there is a possibility of homegrown viral strains emerging as this disease begins to ravage some of the communities in the US that are not well vaccinated. You saw some data earlier about the disparities. This clearly shows that United States, that Native Americans and Alaska Natives and our non-Hispanic persons were the most devastated, with almost 2 times the amount of cases and almost 2.5 the deaths. And of course, African Americans and Hispanics were disproportionately impacted by this disease. And again, this is basically COVID-19 specifically. I just put these numbers up again. I know you saw them earlier, but just to point out that in order to get long COVID, it will come from not just these cases that we see, because these are diagnosed cases, but will also come from the undiagnosed population who had mild disease. And so one should anticipate that the statistics that we see as we go forward from a disparities perspective will be higher than the hospitalization numbers and the positivity numbers that we've seen in our nation. We do know the devastating impact. This is the life expectancy data that was put out by the National Center for Health Statistics in February of this year, where they looked at the first few months from January through June of 2020. And this was preliminary data, which showed that non-Hispanic Blacks lost 3 years of life expectancy, and non-Hispanic Black females 2.3 years, and then Hispanic males 2.4. And I think the important thing, of course, is that this led to an overall life expectancy across the whole society of over a year. And we jump up and down and get excited when we can reduce or we can improve the life expectancy for children, for newborns by 0.2 of a point, 5.5%. We get excited about that. For us to lose life expectancy and for over a year is a really big deal. And it's not just the loss, but it's the loss that we don't get back very easily. It takes a long time to reverse these trends that we've seen so devastatingly hit the community. And these numbers, by the way, have just recently been updated. And this is a new look at those numbers using more data. This is basically two different scenarios, one where the data is moderate, and the other when life expectancy is projected to be more severe. And you can see the difference between what was the anticipated loss of life of lives versus that occurred with COVID. And you can see that we had this shift to the left in essence. So the blue dots are those the life expectancy with COVID-19, and you can see that we've lost substantial life expectancy compared to non-Hispanic whites in both scenarios, both life expectancy at birth and true life expectancy at age 65. So this is a phenomenal hit to the survivability of our communities. And just remind us that we still doesn't seem to have learned our lesson. We're still seeing disparities in vaccination rates in the United States, although there is some improvement in these rates. Hispanic community has done a lot better in terms of improving these vaccination rates than we have in the African-American community, but we have had some improvement in vaccination rates. We still have a long way to go, and we still have states, particularly in the South, which have historically had huge disparities to begin with, that are having real challenges in getting their population vaccinated. In fact, they're still in the 30 to 40% of people getting their first shot, and that remains a real challenge for our nation. So as we pivot to this issue of the long hauler syndrome, just to remind you that as much as 10% of people who've been positive with COVID-19, again, these are people who've been tested, have symptoms for 12 weeks or longer. So this is a disease process that quite frankly is extending beyond 3 months, is another way to think about this. And about a third of the SARS-CoV-2 positive individuals have not returned to their usual state of health as much as 6 weeks post-diagnosis. And even after 9 months, a third of the population continues to have symptoms. And even people need to again remind ourselves that these are not people who are hospitalized. A large percentage of the people, and this was a survey done in Britain, that said that folks had mild illness. And so this is prevalent regardless of where you are. And if you were an ICU patient, that 5% of patients that we talked about, they tend to experience a post-intensive care syndrome. Now that may occur in a variety of patients who've been in the ICU, but as Dr. Maxey knows, because he's taking care of very sick patients in his clinical practice, this gets worse with people that have COVID-19. You saw the list of symptoms earlier, but as well, these, the issue of fatigue, shortness of breath, arthralgias, chest pain. We know that the almost loss of smell is almost pathognomonic of this disease. And just a range of diffuse symptomatology, a lot of this associated with autoimmune type of diseases we see each and every day. And just to give you a sense of the overall picture, again, to point out that this problem goes out long before after people's positivity for COVID goes away. We have this disease process that remains well beyond the month of this actual disease process, and when we can actually see the virus in out of PCR culture. And then the tests, obviously things like fever and having a positive test and abnormal blood panels can identify past inspections, but just remind everyone that in effect, many of these patients don't have any real clinical syndrome that is pathognomonic for this disease. And so it's a disease both of a past diagnosis of COVID-19, as well as antibody tests that show past infection, and then the clinical syndrome, even when these tests all become normal. And that there is some question about whether or not this long haul syndrome both exacerbates existing chronic diseases like heart disease and diabetes and things like bronchospastic disease, asthma, chronic obstructive pulmonary disease. There are people that are looking to see whether or not it precipitates diseases like diabetes. Again, because it may turn on the autoimmune system in some ways that may precipitate some diseases or bring out diseases that have not yet been expressed, which is a big issue. And then of course we have the long-term mental health and side effects. And I know there's someone going to talk about that later, so I won't dwell on that as a big issue. Data is still very sparse about this disease, but we can expect that the existing disparities in COVID-19 prevalence will persist, so that if we had a large prevalence of disparities from the disease, we should anticipate disparities with this long COVID syndrome. And certainly the early data about the disparities in the post-intensive care syndrome are real, and people are beginning to look at that data. I remind us that the social determinants were fundamental in people being exposed to COVID-19 because of what they did. And you can anticipate that the social determinants will play an enormous role in people's recovery. Because if you had insufficient housing, you did not have paid sick leave, you didn't have access to health insurance coverage, or you were in a system which demonstrated bias and discrimination, that did not go away after you got sick. And so I just remind us that they're going to be persistent, and we're going to have to address this as this disease goes on. And we ought to pay attention to the discrimination and the biases within our system as we go forward. And with that, I'll stop and I will thank you. And Dr. Maxey, I will turn it back over to you.
Thank you very much, Dr. Benjamin. I appreciate that. And I learned a lot. I took about 10 pages of notes. That's great. We're going to have you back for questions shortly. It's my honor to present Dr. Lori Newman, MD. She's a medical officer at NIH for enteric and sexually transmitted disease infections. She's at the branch of microbiology and infectious disease at the NIH. And you can see her bio in the chat, so I won't belabor that. Dr. Lori Newman, would you please present?
Hi, first I want to thank you all for inviting me here to talk with you today. It's a great honor to be able to speak about something that I am passionate about. I think this is a really important public health problem that we need to raise awareness about. As Dr. Demisi and Dr. Benjamin have pointed out already this morning, this is an important problem globally. Acute SARS-CoV-2 has caused over 170 million reported cases globally and has led to over 3.5 million deaths globally. And as Dr. Demisi pointed out, this is a huge underestimate of the actual number of acutely infected people. But this is not the story that I'm going to focus on today. What I want to focus on today is the story of the individuals affected by this disease, such as Hannah Davis and Fiona Lowenstein. Members like them of the affected community began speaking up early on in the pandemic, alerting scientists like ourselves of a looming problem of lingering symptoms. We don't know exactly yet how many people are going to be affected by this problem. And I thought Dr. Demisi and Dr. Benjamin's estimates were incredibly helpful. So even if we use a very, very conservative estimate of 10% of those 170 million people affected globally, that's 17 million people that may be affected, that could be affected. And to put that in perspective, that's the same as the number of new diabetic diagnoses each year around the world. And it's 10 times greater than the number of new HIV infections we have each year in the world. A New York Times recent opinion piece said, lingering symptoms from the coronavirus may turn out to be one of the largest mass disabling events in modern history. I think we owe it to the affected people to really understand what's going on and to help ensure that we have the science and the infrastructure and the treatments in place to be able to help people. So NIH is using a term, post-acute sequelae of COVID-19, PASC, and that's what the term I'm going to use today. But this is and loosely speaking right now, we're all talking about the same thing when we talk about long haulers, long COVID, and post-acute and post-COVID conditions. We're not talking about the acute infection that's happening on the left side of this screen, where you have an immediate rise in virus that declines over time. What we're talking about are these long-term symptoms and findings that are being identified by people. They may be continued or they may even be new. And we're calling this the post-acute experience. And this is what I'm going to be talking about today. And I'm just going to use the term PASC for simplicity. So I'm going to cover today the clinical manifestations of PASC, our current understanding of the pathophysiology of PASC, and the NIH strategy for filling these gaps in knowledge. So first, let's talk about the clinical manifestations of PASC so that we have a sense and a common understanding of what we're talking about to the best of our knowledge at this point. The first study that I want to show you is an excellent review that was published recently by a group at Stanford who looked and was able to identify 45 studies. And among these 45 studies, these studies covered about 10,000 patients. And the most important message I've highlighted with the yellow arrow, which is that on average, they found that about 70% of people had symptoms that persisted for at least 60 days after diagnosis or 30 days after hospitalization, 70%. The most common individual symptoms were dyspnea, fatigue, memory loss, insomnia. But it was clear that they were wide-ranging and varied. Unfortunately, however, to date, the evidence is very varied in methodology and hard to compare. And there's not a standardized design. But the take-home message is that PASC is persistent and symptoms are varied. Last week, a very interesting study came out that Dr. Benjamin just showed some findings from, which was that, and Dr. Demisi, sorry, which this study used private health claims data. And they were able to study 1.9 million people with COVID-19. So far, this is the largest study of PASC that I've seen to date. And these people were diagnosed with the initial COVID between March 2020 and February 2021. And in this study, they defined long COVID as symptoms lasting greater than 30 days. And they found that over half of people who were hospitalized had persistent symptoms, and even 20% of those who are asymptomatic had symptoms. So take-home message is that PASC is more likely if you've been hospitalized, but even if you haven't been initially symptomatic with your SARS-CoV-2 infection, you could show up with symptoms later on. And this is quite sobering. There's a recent study that was done in the UK by Ayub Khani and colleagues that looked at hospitalized patients. They compared hospitalized patients who had been hospitalized for COVID-19 with 50,000 of them with 50,000 patients who had been hospitalized for other reasons and matched them in terms of age, race, and sex, for example. And what they found is across the board, increases in signs of multi-organ dysfunction, such as diabetes, a 1.5 increase on average among all these different demographics of multi-organ dysfunction. Similarly, they saw severe kidney disease in an average of about 3 times greater in these patients hospitalized for COVID. They also looked at death and readmission. Death was 8 to 12 times more common among those who had been hospitalized for COVID, and readmission was 4 times more frequent when looked at over 30 days out from the initial situation. What's most important at this symposium, though, is to look at what they saw, for example, in individual organ areas. For example, in respiratory disease, in non-whites, they found an 11 times greater risk of respiratory disease in non-whites than whites who had been hospitalized for COVID. This sort of disparity is really important to understand because we, as it was highlighted very nicely by my colleagues, we're definitely seeing in the United States an increase in acute infection in our minority populations. We don't yet have good data in the United States yet for what these disparities are in terms of PASC, and we urgently need to understand this. Now I want to show you an excellent study that was done by Al Ali and colleagues using a Veterans Affairs database. They looked at 6 months out to look at what the excess burden of disease was in 75,000 30-day survivors of COVID-19, and they then compared those to about 5 million users who didn't have COVID-19. And these, again, they're looking now at 6 months out from their initial infection. And what they see, I don't expect you to be able to even read the numbers on this slide. Look at the colors. Each of the colors in the first column represents a different organ system. And what you find in rank order, in descending order of excess burden, and what you find are that organ systems, many, many different organ systems were affected 6 months out. Similarly, in terms of incident medication use, all different classes of medication uses were used more frequently by people who had had COVID 6 months out. Some of these including pain medications, including narcotics. In the third column, we see that many different lab abnormalities that were important. And I put the box around 2 that I thought particularly concerning, which was anemia was more common, and so was elevated hemoglobin A1Cs. To me, the key message that this study showed is that the burden is enormous on healthcare. The potential burden on healthcare systems is enormous 6 months out and longer. We don't have data for longer yet, but this is a substantial burden of health loss that we need to be prepared for with multidisciplinary strategies. So now I want to switch to, in order to actually design treatments and interventions, though, we have to have an understanding of the possible pathophysiology of PASC so that we can design treatments for people like Hannah and Fiona and the many other people who are affected by this condition. So as was pointed out, as many of you were aware, the virus affects acutely, the virus enters the cells through these ACE2 receptors. And an acute infection, we know affects multiple organ systems. So it's not a surprise at all to see why and imagine why PASC is similarly affecting multiple organ systems. So there's many different possible mechanisms for PASC, though, because what we're seeing is that initially the viral load in most people declines after about 30 to 40 days. And we are seeing some signs of viral load later on. But for this virus, the direct cytotoxic injury to be the only mechanism, we would need to have very strong evidence for reservoirs of infection that could be reactivated. But that is probably playing a little bit of a role in this situation because we are, for example, seeing viral reservoirs in the gut. that last longer than the viral reservoirs in the nose or the respiratory system. Another possible mechanism is through these ACE2 receptors, and those ACE2 receptors are an important part of the renin-angiotensin-aldosterone system that regulate cardiovascular functioning and blood pressure, for example. Similarly, we're seeing endothelial damage, which could be leading to micro and macro thrombotic events. And we're seeing dysregulation of the immune response. So either hyperactivation of the immune system or hypoactivation of the immune system. In all likelihood, though, it's not any single one of these pathways, and unfortunately, it's maybe a combination of these pathways that is affecting people. So what is NIH's strategies for filling these knowledge gaps so that we can actually come up for solutions for all of you, including people on this call today who are affected by this problem? In December of 2020, NIH held a workshop on PASC that brought together 1,200 participants virtually that included epidemiologists, clinicians, basic and clinical researchers, and many members of the affected community. And the point of that workshop was to identify key gaps. These key gaps were then, the concepts that identified at this workshop were then brought to an initiative that was the result of Congress providing $1.15 billion for PASC to NIH over 4 years to support research in this area. This initiative is called Recover COVID, and I'm going to tell you all a little bit about that today. So what is Recover? So Recover is an initiative at NIH that's going to try and understand, prevent, and treat post-acute sequelae of COVID. It's a trans-NIH initiative because it involves every organ system and every aspect that NIH covers. It aims to help those experiencing the long-term health effects and to better understand the public health impact of PASC. And we fully anticipate involving and engaging the affected community in the design, implementation, and interpretation and translation of this scientific endeavor, especially making sure that we have adequate representation of the racial and ethnic minorities that we think and believe are disproportionately affected by this situation. The priority questions that we're focused on are going to be, what does the recovery from SARS-CoV-2 acute infection look like among the different groups? How many people continue to have symptoms after the acute infection, continue, or have new symptoms after the acute infection? And what is the cause or the underlying pathophysiology of these ongoing symptoms and health effects? And why are there disparities? Why are some people affected and others not? And does it put people at increased risk later on in the future of does it put people at risk in the future of other disease pathophysiologies like brain disorders, heart disorders, or lung disorders? So the structure of the Recover Initiative cohorts, there's a series of clinical cohorts that are going to enroll people acutely infected and follow them through time. And unfortunately, the pandemic has not slowed enough, and we have many people that we will be able to enroll from the initial point of infection and follow them out over time. We hope at least 2 years. There's also going to be people who already have PASC, and we want to enroll them in these cohorts to do a deep dive and understand what's going on with them in all of the different manifestations. We're going to need to also bring together a large cohort of electronic health records so that we can also look at things that are more unusual and rare and can't necessarily be seen in a clinical cohort unless it's of a massive size. And unfortunately, we do need to also do autopsy studies because we really need to get tissues and understand at the micro level what is going on in people. So overall, the goal of these clinical cohorts is to understand and be able to treat and prevent PASC. And we have an overt aim to make sure that this is a national, inclusive, and a diverse patient population that spans the entire life cycle. The research is going to be adaptive, so we respond to this pandemic, and we are going to make sure that it's using a common set of protocols and data elements so that we can ensure that these findings are translatable, not just to other people around the country, but other people around the world. I'm going to wrap it up by providing a few words from Francis Collins, who is the director of the National Institutes for Health. PASC and the individuals suffering from it can no longer be a hidden toll of this pandemic. NIH takes this problem very seriously. We feel like it's going to take incredible collaboration of effort from people across government, in academia, in the private sector, and the affected members of this community to work together to try and find solutions so that we can ensure that people like Hannah, Fiona, and the many others of you on this call today who are suffering from this problem can find answers and return to your baseline state of health. For those of you who are interested in more information about this initiative, this NIH initiative, here's the website, and I encourage you to go there. We will try and keep it updated and use it as a site that we can promote information and share and raise awareness of this problem. Thank you very much.
Thank you very much, Dr. Newman, for this very astute talk. And again, I took pages of notes that we'll talk about a bit later. Thank you so much. I'd like to introduce our next speaker and the final speaker for this particular section, who is Dr. Matthew Cuevo, who has a bachelor's, and he also has a PhD, is an assistant professor of health economics at the London School of Hygiene and Tropical Medicine. You can see his information in the chat box. Dr. Cuevo, please speak to us.
Thank you very much. And first of all, just to say it's a real pleasure to be here in this very, very illustrious panel. I think the organisers have put me on this early because I'm based in London, and at the time they're being friendly to me because of the time difference, not because I can compete with the CVs of some other presenters. So yeah, very grateful to SUNY Downstate Health Sciences University, Black Health Trust, Brooklyn Health Disparities Centre, and all my colleague speakers for their talks. My name's Matt Quaith. Like I say, I'm calling in from London, and it's been one of these real, I guess, differences of COVID in the way that we work, that it's so exciting to join this meeting. That's something that I wouldn't be able to do otherwise, and hear the perspectives of all the excellent work going on. So I've been working on COVID, and specifically COVID modelling, over the last year as part of the London School of Hygiene and Tropical Medicine, or LSHTM's Centre for the Mathematical Modelling of Infectious Diseases. So we've been heavily involved in modelling the COVID-19 pandemic since early 2020. This is a message from our Slack group going back to 20th of January 2020, inviting people to an in-person meeting. Can you imagine an in-person meeting about this nCoV-2 and what, if anything, we might want to work on? As of yesterday, our group has worked on 138 separate analyses or papers or reports around COVID-19. There's many in progress, and I'll make the slides available with this site, a link to the site that has an updated repository of all of those. We put all of our working papers, all of our code online, so you can go and recreate what we've been doing. And this work has been pretty influential in the UK, in particular, feeding into our government's response to when to lock down, how to lock down, alongside some other groups at Imperial and Warwick and Public Health England. This is from the BBC. It's nice to see the LSHTM name up in lights, even if it's not a particularly cheery y-axis that we see there. I'm going to talk about three things, and I think actually my previous speakers have really dwelt on these as well, but I'm going to give a kind of a modeller's perspective. So first of all, getting under the hood, that people have talked about these models for the last year. What are they? How do they work? And why do we care about them? I'm going to talk specifically about how we model morbidity and mortality and relate that to measures, some previous work that we've done around a not too dissimilar condition of tuberculosis, and also some work around long COVID, and then finish up with where next of our known unknowns. I'm going to use the terminology long COVID because that's what the conversation is in the UK. So I'm not ignoring the other terminologies. It's just something that I'm familiar with. Okay, so let's pop the hood of this transmission model. What are they? These are models that they're population based, although some are individual based. They're basically these systems of differential equations, and this is an example of our main COVID model conducted by my colleague Nick. People move. People are in these bins of susceptible or exposed or clinical or removed. People move through this model at different rates. This first arrow, people move from being susceptible to being exposed at the rate of infection. So your likelihood that a given behavior leads to you getting infected, you move along this model. And basically people flow through this model here. Because of COVID's nature, we have a clinical or a symptomatic set of compartments at the top and a subclinical set of compartments at the bottom. The rate at which people move through these models is calibrated based on data. So we know how many cases we have, we know how many contacts people are having, we try and calibrate these different arrows based on those data. These models are also what we call dynamic. So my likelihood of becoming infected today in the model depends on how many of people around me are infected and infectious. This allows us to replicate these really interesting epidemiological dynamics, things like these exponential rates of increase as people get vaccinated or not, become immune or not. So what's driving these models is basically a spreadsheet. It's a column as a spreadsheet and people are moving across. We don't consider that people are different. We don't even consider that people have different characteristics or mixed with different people. The primary driver of these models is contact patterns. So for respiratory pathogens like COVID, we impute these contact rates. So I'm going to highlight just up here, this top left grid. This is for Pakistan. This is this could be you, this or me. This could be any respondent of a survey. We asked, who did you come into contact with yesterday, and what age were they? We can see here that there's a reasonable amount of age assortative mixing. People mix with people of similar ages to them in the home. There's also here, these parallel stripes are a generational effect. So people are more likely to mix with people who are 20 years apart in the household, and more likely to mix with family at home. Across different settings, these contacts are really different. So at home, we're more likely to mix with people of different generations. At work, we're more likely to mix with people who are of similar ages to us. At school, you know, it's only young people going to school. There's a few teachers at school. Of course, we're going to see that. So I'm showing you this because these are the key parameters that drive the results of these models. We have the population age structure as well. Again, this is for Pakistan, hence a wide pyramid. We also have symptomatic case outcome probabilities. What happens if you get COVID? What's your probability of becoming hospitalized or passing away? This is an example of the output of the model, and it looks like quite intimidating. There's a lot going on here, but there are basically these 5 non-pharmaceutical interventions that we ran: school closures, physical distancing, shielding, self-isolation, and a combination approach. Now, I'm showing you this because this is what our models currently churn out. These are the indicators that we look at. So, for example, we're looking at cases, we're looking at deaths, we're looking at peak ICU beds. You know, these are things that are easy to measure. They are things we're immediately interested in. We need to know today how many beds we'll need tomorrow. These are also things that are comparable across countries, across regions, and across age groups. And it's for those 3 reasons why we rely on these measures: cases, hospitalizations, and deaths. As Leon, our first speaker, said, cases and deaths have been the focus of this so far. That needs to change. They've been really effective on focusing on public and policy discourse on, you know, immediate prevention of should we or should we not lock down, should we enforce mask wearing and school closures. And this has been quite a period of urgent and reactive and emotive decision making, which is pretty unusual. And at the moment, we are getting towards a stage where, with vaccine rollouts going pretty well in the US and the UK and in other global north countries, this may be a return to normal decision making of the costs and benefits of different approaches. But this return to business as normal modelling means that we need a much more detailed and nuanced understanding of COVID, and that starts with long COVID. And we need to count how COVID-19 contributes to ill health. This is a key message of what I'm going to talk about, and I'm going to highlight it with a GIF because I'm so concerned about you taking this message away. We need to count how COVID contributes to ill health. If we're just looking at deaths and cases, countries and regions with younger populations might not receive their fair share. We've heard also about different groups, socioeconomic, racial groups that have different rates of COVID and long COVID within countries. We need the right metrics to help us measure that. So what are those measures? How do we use them? So I'm a health economist. Health economics gives us a toolbox of how to make the case that morbidity matters. We have these 2 measures of QALYs, quality adjusted life years, or DALYs, disability adjusted life years. These are standard tools of measuring both quantity of life and also quality of life. A QALY is 1 year of perfect health, or it could be 2 years at half health. It means that we get both of those dimensions on the same graph. They're multidimensional, so they combine both morbidity and mortality. They also allow us to compare across health conditions, and that's the power, that we can compare an intervention that will prevent a case of COVID against buying a new MRI scanner or a different vaccination regimen. We can compare within our group. So these are really powerful tools to measure both morbidity and mortality. An example of how we've used this kind of a slightly more developed stage than we have in COVID at the moment. So we think about tuberculosis. In many ways, a similar disease to COVID. It affects people who are already kind of, so it's a respiratory pathogen, and it's got extremely structural determinants that goes with income and wealth and how people mix. There's evidence that shows that individuals who complete TB treatment are almost 3 times likely to die compared to people who haven't completed TB treatment. Yet at the moment, our models just assume that when you complete your tuberculosis treatment, you go back to full health. You're like the person you were before you got tuberculosis. That's not the case. That's mortality. On morbidity too, there's anecdotal and small number evidence that there's a lot of morbidity from things like residual tissue damage, despite microbiological cure, and tuberculosis is also associated with things about airflow obstructions and things that are impacting your airway. And this is an example of this framework in which we're able to analyze this long tuberculosis condition. So we have, the further up you are on this axis, the healthier you are. We have someone at full health, they get TB, they have a period of time where they're sick. What happens at the moment is that we assume people go back to full health, but actually this is their morbidity difference, and this is a mortality difference. Within this framework, we calculated, we took India as an example of this analysis. We said that let's consider DALI losses because of post-tuberculosis impacts. It increases the number of DALIs caused by tuberculosis by half, by 54%. That's an example from tuberculosis, and actually some colleagues of mine at the London School of Hygiene and Tropical Medicine, Professors Andrew Briggs and Anna Bassel, have done this for COVID, albeit with slightly more early stage data. What they did was they looked again at Pakistan and the UK. You can see the different age groups, talking about comparing across countries and across settings. Again, they assumed that long-term COVID morbidity arose in 10% of those acquiring COVID, and it sounds like that's not too bad an assumption from what we've heard today. We've also assuming here that the DALI loss is half a year per long COVID case. So what that means is, and it's not based on data at the moment, and this is why my focus on this presentation is about counting, every long COVID case is equivalent to losing half a year of full health, or reduced, or living for a year at half health, or 6 months of life at full health. They approximate the health burden due to COVID-induced disability could be around 30%. So we're going to increase the negative impact of COVID by 30% if we include post or long COVID sequelae. This is just their figure that says the same thing. So Pakistan is 0.31, in the UK it's 0.26. Now, I'm going to finish off here by talking about where next for modelling and talk about some known unknowns. So we need to move beyond assumptions. That half a DALI figure that I came for, we basically have had to make that up because the data aren't there. So it's critical that we start counting the health impact accurately. There's the count again. We need to start counting. It's important because there are generic and there are respiratory condition specific tools that help us do this. And many practitioners will be familiar with the St. George's Respiratory Questionnaire, which looks specifically at people's shortness of breath and coughing and respiratory related morbidity. There's also generic tools like the EQ5D3L, which aim to measure how much morbidity different conditions cause. These exist now. They might need some tailoring. We saw Dr. Benjamin, I think, showed the huge range of long COVID symptoms. We may need to adapt our tools to measure these, but it's urgent we do that now and start measuring. We also need to think a bit beyond health. So as a group of modelers, we're really good at thinking about health, but we're not so good at measuring the economic impact. And economic impact comes in three ways. It comes on the direct costs of seeking healthcare, indirect costs of having time off work when you're sick or caring for someone, or there's also the macroeconomic level productivity losses. Again, we can learn from other conditions, and specifically tuberculosis here. This is a link here to the patient cost survey, a handbook of the WHO, which gives a good guide of how to do this sort of measurement. We can use that experience from other disease areas. And I put two quotes here. We have a regular kind of meeting group. These are quotes from two advisors to the UK government this week, as we talked about long COVID. I'm just going to read them both. So infectious diseases are scary, but also they're sexy. Their long-term implications appear less so, but they are just as important and need to enter the standard discourse about prevention and care. So I think we're preaching to the choir here. People of this meeting will understand that. Big numbers influence policy, but big costs can influence it more. So let's bear that in mind as we start presenting evidence to people. Finally, we're not the same, and it's really it's really notable, right, that here I am. I look like this guy on the right-hand side, and not many of us on the call look like this. We need to understand heterogeneity in people's experience, and again, I think my fellow speakers have spoken to that much better than I can. So I'm going to talk about the domains we need to measure it in terms of the physical and mental health impacts, social impacts, and economic impacts. I'm going to finish there and acknowledge the COVID working group, the professors who I mentioned, and the funding from my group. Thank you again very much for having me, and good luck with the rest of the conference.
Thank you, Dr. Moesi, for this most grateful lecture and talk, and very interesting with the numbers from across the pond. So thank you. We have 10 minutes for question and answer. And I'm going to address this to the entire panel. One of our attendees is an 11 times marathoner, and he has COVID and long haul syndrome. And he's wondering if there has been a report of long haul syndrome affiliated with athletes, and if there are any treatments or approaches that we know about. He is affected with shortness of breath, fatigue, easy fatigability. And I'd like to ask the panel from a practical standpoint, what do we know about the association with athletes and treatment?
Hi, this is George. Let me just say one thing. There's no specific correlation with athletes versus others, if that's his question. But let me also ask the question: is he vaccinated yet? Because he still should get vaccinated if he has not. We don't know that makes a difference, but we do know that native infection does not protect you from being reinfected with COVID, as well as being protected if you're vaccinated. Vaccination seems to probably provide a little more protection. So that's one thing that they can do in terms of looking forward. And obviously, none of us can practice medical care over the Zoom for a patient that we've never seen. So I always encourage people to see their physician to get more specific medical advice.
Okay, and this question again is for the group, but especially Dr. Newman, and that's concerning the Recover program. Is that still active, and are they going to make certain that communities of color have adequate time to register to be involved in that?
Yeah, I just want to add on to Dr. Benjamin's answer about the guidance for management. The CDC recently came out with some guidance about to assist with post-COVID condition, management of post-COVID condition. They're calling them guidance, not guidelines, because there's an insufficient amount of data and evidence available right now. I'm going to pull that link up and put it into the chat for people. But I think that is for all of the clinicians here to be aware of it. It's broad, it's general, it's not going to answer all of the conditions and situations that are encountered And it certainly doesn't specifically talk about the tough situation that the marathoner who wrote this comment is asking about, but it is a starting point for of clinical guidance. So I'll put that into the chat in just a little bit. With regard to your second question, NIH is working very, very hard. One of the key questions that we're hoping to address is why are some communities, who is affected by this? To get at the epidemiology, none of the presenters here today could show you definitive evidence about what's going on. We know that this is going to disproportionately affect communities of color because the acute disease is so much more severe. So we know that PASC is going to have, but we don't know is if the proportion is if PASC is even worse in minority population, that it's an even worse problem. And we don't understand that yet about the racial disparities associated with PASC. There's just not good evidence yet. And that's one of the priorities that Recover is working on. When we selected the initial, so the Recover initiative, sorry, I didn't give you an update on the status of it. It's just got, the initial sites were just selected just last week. And we have 35 investigating sites distributed across the country who were selected not just for their technical expertise and their geographic diversity, but also to ensure that they could enroll and engage affected minority communities. And we spent a long time ensuring that they can not just enroll, but over-enroll and over-sample, because we think that there's actually going to be some, we do think that there's going to be some disparities associated with PASC, and we want data and evidence, and we want to make sure that then the pathophysiology is done not just on white communities of color, white individuals. We have a long history in this country of not making our research diverse enough. And this is a very overt and intentional effort by NIH to ensure that that history is not carried on into the future.
Thank you. But Dr. Nemesi, with regard to the variants that we're coming up with, how does our rate of vaccination of our communities affect the appearance or production of variants? And also for Dr. Kwesi, how does this affect the economics and the predictions in various communities of color? I'm concerned that although we may be 50% vaccinated in the United States, are we creating a better risk factor as other communities come to America or we go there?
Yeah, thank you. So as far as the virus keeps circulating in the population, the probability of developing mutation is very high. That's why we have so many variants. And in order to stop, the spread of variants, the best strategy is to be able to vaccinate a large segment of the population globally, and also in the United States. But that is not going to be easy, especially globally. It's going to take a lot of time to vaccinate a lot of the people in the several countries. So because of that, still we're going to have a lot of variants in the future. Some are probably not going to be variants of concern, but some are likely to be variants of concern. So the best strategy is a global strategy to vaccinate as many people as possible globally, because a variant developed in Africa, it will not take a lot of time to come to the United States because the world is so connected today. The viruses can, be imported in a very short period of time. So vaccination is we have to really stop the replication of the virus. That's how mutations occur when the viruses are replicating. Unless we stop that, there will be variants.
Dr. Kwesi, I'm very concerned, as are others, about the economic impact. We heard earlier that there's a decreased life expectancy, especially in communities of color. What do you see in the cards that you presented, how we as physicians can better utilize your models? And how does this affect the economic growth of communities of color, especially with decreased life expectancy, if that's correct?
Thanks very much. I think that's such an important question. So my first response will be to take you back to that quote I presented, that costs matter, costs cut through the political discourse. But to know the real economic impact on individuals, on households, and on societies, we need to measure these things. And it hasn't been a discourse that in the UK has been present to date. So I go back to my message that we need to measure these things, we need to count. And it matters from people sharing their personal experiences of not just the conditions of long COVID, of how it affects their health, but how it affects family life, how it affects ability to work, and measuring these economic impacts systematically, I think is the critical next step to make the argument that this is worth spending money to prevent and to deal with. Over.
A question to the panel. Many of us are the local practicing physicians, not necessarily in academia. How can we, with our patient base and our electronic medical records, contribute to the search for answers as we go forward? And also, if any one of you has a crystal ball, have we really turned the corner, and what's coming in September and October? That's to the entire panel. I'll start with Dr. Benjamin.
I missed your question.
What are we facing in the future as far as long haul is concerned? Have we really turned the corner with this particular pathology? And what can we as local practicing physicians, not necessarily affiliated with academia, do in terms of providing information and insight?
No. Well, we're in for a growing number of people being identified with this disease, and certainly the ones that'll be obvious, people who have had COVID and been hospitalized, is the obvious initial cohort. But we're going to have lots of patients that are going to be presenting to their doctors over the next several years. Well, let's say from months to the next 2 or 3 years at least, with vague syndromes and complaints, and we need to do a pretty good history. It's going to take a lot of do a good history about what their exposure was during the COVID outbreak, doing the antibody tests to see if they were infected. I do think that we're going to have to get a better understanding of the history of results of these tests. And then, as was stated earlier, follow the guidelines that the CDC has initially put out for both the identification and management of these cases. I believe that this is going to be a big part of and a growing part of the practice for primary care practitioners. And I would also remind us that for many patients, their care is provided by nurse practitioners, physician assistants. So we need to make sure that they, of course, are also as well knowledgeable of this, and OBGYNs, because for many of people at least in the United States, and I suspect this is the same around other nations, the OBGYN, for all practical purposes, serves as a primary care practitioner for those patients.
Well, thank you so much. I'd like to thank all the members of our panel, Dr. Demisi, Dr. Benjamin, Dr. Newman, and Dr. Kwesi, for such astute information. And it gives me great pleasure to introduce to all Dr. Ivan Walks, who will chair the next session. Dr. Walks.
Good afternoon, everyone, and good morning to those in other time zones. Dr. Maxley, thank you for an excellent presentation. I think all of us are going to run out of paper taking notes today. I would like to start our program by introducing Dr. Patrice Harris. Dr. Harris is a past president of the American Medical Association. She was the 174th president and the first African-American woman to be selected to that position. She is co-founder and CEO of eMed, a digital healthcare company, and is a visiting professor in the Department of Psychiatry at the Columbia University College of Physicians and Surgeons, and also an adjunct professor at the Morehouse School of Medicine and the Emory University School of Medicine, and a fellow of the American Psychiatric Association. Dr. Harris, please talk to us about brain fog and cognitive disorders.
Well, thank you very much for that wonderful and short, appropriately short introduction, so we can make sure we get as much time in as possible to talk about the subject of the day. And thank you also so much, Dr. Maxey, for pulling this together, because we need to have these conversations right now, particularly about what I call the neuropsychiatric symptoms of COVID long haul syndrome, because typically we wait until after the fact to have these conversations about the neuropsychiatric sequela, the psychological sequela. And so I'm very happy to just whet the appetite of some, and I look forward to hearing my fellow panelists. So I'm going to attempt to share my screen. It's always, you let me know if you see my screen.
Yeah.
Yes, we do.
Very good. And so it's important that we have this lens, because as I said, most of the time we think about mental disorders and mental illnesses, and then even the neuropsychiatric symptoms after the fact. And so what I want to leave you with today, the take-home message is, let's make sure we are having these conversations and including an assessment and evaluation and understanding of these symptoms at the beginning of our quest to understand what's going on here with these folks who have longer term symptoms. And I think first and foremost, we have to start with some principles, because I think if nothing else, this virus should have taught us all to be humble. I've said in many times that this virus gets an A+ in doing what viruses are supposed to do, and that's replicate, figuring out a way to continuously replicate and change, and sometimes thwart us at many levels. However, we do have a vaccine now, and that is great news. However, I think we all know that we need to be on guard for these variants. But I think as we even think about long haul symptoms, we don't know a lot of information. Again, one reason why it's good that we are having these beginning conversations, and we will have to continue to have these conversations, but we will have to remain humble and know that we are just beginning to learn about these symptoms. The next is language, particularly around the neuropsychiatric and the psychological aspects. I can tell you, now listen, we came into COVID with difficulties with language around mental health. Is it mental disorders? Is it mental illnesses? What do we say about addiction? And we have appropriately progressed and are appropriately using less stigmatizing language, but it's still a little bit confusing. Just a quick example, I was asked to do a story, and so I was talking to the reporter, and I wanted to get clear from her if her story was about the neuropsychiatric symptoms, brain fog, difficulty word finding, some of those symptoms, versus the psychological stressors of the pandemic and what people are experiencing. And she said one thing, but then she would easily bleed into the other. So I just think, again, it's difficult. I do not have the answer, but I think we should endeavor to be real clear and specific about the language that we use, and agree at the very beginning of conversations what we are talking about. And we'll just have to continue to be mindful about our language, and that includes language around equity, because really the whole conversation around this work needs to be centered around not only patients, but equity. And of course, as a psychiatrist, I'm biased, understanding these sequelae. And again, my point, nuanced point about being proactive and coordinated, I have to say, typically, sometimes we will go through our differential, and the last thing on the differential is even inclusive of anything that might relate to the neuropsychiatric or the psychological sequela. And I hope we are getting to the point where we are just considering all of these on intake, right? We are asking the appropriate questions. We are asking the questions around equity and how COVID may have affected your life, and who perhaps may have died from COVID. And we know that more of our patients from communities of color were more likely to experience that. So it's about being proactive, and it's about being coordinated. And you'll see at the end some suggestions I make about the importance of ensuring that we use an integrated approach. I know across the country, there are centers that are set up to address these patients. I want to say, I'll say it now, and I'll probably say it several times throughout this presentation. Make sure psychiatrists, psychologists, other mental health professionals are a part of that. There should be a link ahead of time to be proactive. What questions should we be asking? How should we manage? And what are the resources going forward when patients present with some other symptoms? Again, we have all seen the impact, again, of COVID-19 on mental health. Of course, COVID amplified so many fault lines, health inequities, the lack of a public health infrastructure, the lack of a mental health infrastructure. And so we came into COVID with those fault lines. And of course, they've been further amplified through COVID. And I think if you look at survey after survey, again, the good news is we were asking these questions. We know that COVID-19 has had an impact, but we have to also, again, be careful of our language, because people confuse symptoms. I may have sadness for a week. I may be anxious for a week. I may have sleep disturbances. That does not mean I have a disorder, right? All are critical, all are important. And so I heard so many folks make the leaps. Some of these surveys say 25% of folks reported an increase in anxiety. And then I would get the question, 25% of folks now have an anxiety disorder. Again, so that gets us back to language and making sure that we are separating out the two, but clearly all are important and deserve a plan. We should be, again, planning and preparing now. I typically, those of you who know me know that I'm typically not prone to hyperbole. And so you might not hear me say things like we're going to have a tsunami of mental health disorders when we get on the other side of this. But listen, a lot of issues. I mean, even if we look within the health professions, within the medical community, we again came into COVID with burnout and a lot of issues. And this was quite difficult and stressful, particularly on our frontline workers, but really not all. I received several texts over the course of the pandemic where folks, psychologists, psychiatrists are saying they're treating colleagues and they are, again, experiencing their own issues. So again, so many threads to unpack there. We just need to know that COVID-19 has had an impact on mental health, again, from the broad spectrum, from psychological stressors. Our lives have been disrupted, to the actual neuropsychiatric sequelae. And what are those? Again, many. This slide just gives you a few. The most common, at least I've heard, is people talking about brain fog after they, of course, have had the illness. And by the way, again, most often occurring in those who had more severe illnesses, moderate to severe illnesses, but not limited to those, even those who had a mild illness course. And let's remember this, in the very beginning, what were we telling our patients? Our hospitals were overrun at the very beginning. And so we really told folks who were experiencing moderate illness to stay home. So again, we cannot equate serious illness to hospitalization, because remember what we had to out of necessity at the beginning of the pandemic. And so we probably saw some patients who had a moderate course of disease who fortunately got through that at home, but they feel like they just are wading through and going through slow motion, just a brain fog, can't think clearly, trouble concentrating, memory loss, word finding difficulties. And then you see some other issues around, anxiety and a sustained depressed mood. So again, we're not talking about, we have an event and then we have a brief period of a depression or anxiety, but a sustained depressed mood. Again, difficulty sleeping, appetite changes. These are just a few. We've unfortunately saw an increase in misuse of alcohol. Those who could not call on their typical coping strategies. And believe me, that was difficult. That was difficult for me in the midst of everything, again, COVID and the social injustice and an attack on our democracy. But we saw folks who were misusing substances, which then further worsened any issues they were having around cognitive impairment, brain fog, difficulty concentrating. I also saw, and we've also read about folks becoming, suicidal ideation, feelings of hopelessness and helplessness. And we've seen those, again, who were, that was a reaction to the disruption in their lives. But we've also seen that in those who, again, had some of the neuropsychiatric symptoms. And we've seen issues around survivor's guilt, or we've seen issues around folks who, again, didn't have the privilege of working from home and may have, through, of course, just the circumstance, infected others in their family and feeling guilt about that. So we see a wide variety of symptoms. And what is the etiology? Is it the actual disease or the infection, the inflammatory process? Of course, we all know folks who've been in the ICU, and we all know their cognitive difficulties after being in the ICU. First of all, being in the ICU during that time when you never know if it's night or day, and a lot of noise going on and bells and whistles. And then remember, during this time of COVID, all of the caregivers wore masks. So you didn't even have the opportunity for that connection, which could help and did help in typical times. Of course, we use high dose steroids, and we know those impact cognitive function, also psychosis, mood swings, and of course, ventilation. Could this be a very slow resolving delirium? I've already talked about, of course, being in an ICU, not again, being able to have visitors, again, the mandated isolation, mask, health professionals, as I mentioned, survivor's guilt, and near-death experiences. And actually, I use the medical term, just plain scary, right? From soup to nuts, this was just plain scary. I know that's not in the DSM, but I think that's plain language for what could be a compounding factor in this sort of long haul syndrome. And again, the psychosocial stressors of the disrupted lives, missed milestones. We didn't have our normal coping mechanisms, right? We didn't have the ability to go perhaps play a game of pickup ball, or I didn't have the ability to go to a Falcons football game, which was one of my stress relievers, or shoe shopping, which was one of my stress relievers. So we were again, we really had a limited cadre of our usual coping mechanisms. And of course, nothing happens in a vacuum, as you all know. And so some of these issues are compounded by, of course, where we are in a divisive political environment. It was an election year. Police brutality, racial injustices, again, not new, but again, amplified during this time. And we know economic factors, job loss, unemployment also cause increased stress. And again, those who had previously diagnosed, clinically diagnosed disorder, anxiety disorder, depressive disorder, substance use disorder, they had a disruption in their ability to get to their usual care and supportive services. So certainly all those have contributed. So again, my question is a constant question I ask, and now that we have this information, what are we going to do about it? And clearly policy is a foundation for work going ahead. Again, we came into this on the foundation of a very fractured, underfunded, under-resourced mental health and addiction system. And so we have to think about that. And one way of getting through this, and again, I noted the lots of clinics that are popping up, but there may not be a clinic in every area. Most of these clinics, if I understand correctly, are in academic centers. And so I think I heard Dr. Maxey say, what do non-academic folks do? And so we need to figure out and develop these sort of systems, many systems of care, and integrating care is critical. The AMA has a lot of policy. The AMA has a roadmap. We've been particularly keen on making sure that our primary care colleagues have the support that they need because we do not have enough mental health professionals to address this. And so certainly you can look to the AMA for a resource. You can also look to the Bipartisan Policy Center. Well, I just wanted to just say quickly, the AMA did develop this behavioral health collaborative. You can go to our website for those. I'm also on the Bipartisan Policy Center's task force around opioids, but the point is here of integrating care to address opioids, to address some of these symptoms regarding long haul. So we have to think about these from the beginning. And then going forward, we have to think in the mindset of a framework for excellence, from being very proactive at the beginning, as I said, promoting, and as these clinics are coming up, making sure we have the vital community conditions so that these issues are hopefully prevented and people can not feel stigmatized about addressing some of these issues to treatment opportunities. So thank you very much for the opportunity to talk a little bit about that.
Thank you so much, Dr. Harris, and we hope that you can stay with us for some questions later on. I'd like to have us move to Dr. Lawson's presentation, and in keeping with the spirit of brief introductions, Dr. Lawson has been a giant in the field of psychiatry across the country. He was a senior person and professor and ran the department at Howard University. Then he was down in Texas. And most importantly, he is a friend to all of us and wants our communities to be healthier. Dr. Lawson, can you please join us and talk a little bit about anxiety and depression in long COVID?
Thank you. And just want to note that it's already well known among this group about the impact of the COVID, the development of the virus, that it was no built-in immunity, reliable vaccine, or confirmed treatment. And also that it was associated with high, initially at least, with high hospitalization, high mortality rate, ease of spread during routine activities. And that in and of itself created fear and anxiety. One of the points that I noted in looking at the history of this is that I was amazed that we were surprised. If we remember, there was the Spanish flu, 5 million were infected, 50 million deaths, massive and sudden loss of life. Many people were in a chronic state of helplessness. A large portion of the population was affected by loved ones. Parents had to come to grips with losing a child. Children found themselves parentless, and the experience left folks with feelings of guilt, anger, confusion, and abandonment. And I said, where had I seen this before? So this was, so the experience we have, unfortunately, is not a unique experience, not only in terms of its effect, in terms of the disease itself, but also its psychological and psychiatric impact in terms of individuals. And in addition to the psychological impact, the psychiatric impact, what we now know is that these disorders, this disorder leads to a viral infection. And even at that time, and subsequent to that, we found that certain mental disorders actually increased in frequency. Bipolar disorder, perhaps autism, schizophrenia, and others. So that the long haul is not simply the impact on the individual in terms of their perception of it, but also may have long-term effects on the brain that are specifically tied to psychiatric disorders. And there's recent studies showing that what we've seen is that a third of patients diagnosed and 6 months after the infection tended to have more anxiety disorders and substance abuse disorders, as Dr. Harris noted. And the most common ones were anxiety, mood, substance abuse, and insomnia. I'll say a little bit more about this, but basically there's a doubling of risk of newly diagnosed psychiatric disorders. And so there's an acute effect that has long-term consequences. And the neurological and mental health disorders were more common than what you would see in flu or respiratory tract infection. So it says there's something about COVID-19 that is really impactful on the brain. And the main psychological impact is on stress or anxiety. But again, initially the interventions that we used, quarantine, had effect on many people's usual activities. And as a result, their routines were disrupted, their livelihoods were disrupted, but also levels of loneliness, depression, harmful alcohol, drug use, self-harm, or suicide were also rose. And if you look at 1918, in some countries, the suicide rate jumped substantially. And these were associated with feelings of fear, anger, sadness, and also frustration. So over the long haul, what we find is that people lose energy, activity levels, difficulty concentrating, making decisions, difficulty sleeping. And this has an impact in terms of their ability to return to such things as interacting with family members, as well as the impact on being able to work at a job. Talk to folks who are involved in terms of IT, and they just can't do their work. And well known that those folks who lose the sense of smell, sense of taste, and who are chefs, this really has negative consequences. The other component about this is that in addition to a direct effect, there's the worry and stress over the coronavirus. It seems to many people it comes out of the blue. We like to attribute things that happen to something we do, something that's happened in the environment. But in this case, what we have is folks suddenly finding that they couldn't sleep, lose their appetite, and there's nothing going on that they themselves can directly see. Those particularly after they've been told that they've recovered. So here's a case of some of the questions. Should teenagers wonder, can they visit their elderly relatives? That's changed somewhat with the availability of vaccine, but then you have to wonder who's been vaccinated. And we know that a substantial number of people haven't been. Should grandparents babysit? And also, I've talked to a number of patients who are just worried about their jobs, not only if they have been infected or not, but in terms of going to their job, who other employees had been tested or infected. And there are requirements about the job that they must show up to work. So a large percentage of folks have anxiety and depression. And also, women with children are more likely to report these symptoms, and higher rates of anxiety and depression compared to men. And again, let me just emphasize the impact of loneliness. Many people have self-isolated themselves, refuse to go out, difficulty going outside. I have patients who literally have only gone outside to go to the grocery store or had it delivered to them during the pandemic. When they've gotten vaccinated, when they say they can go out, either they've lost their friends, they've lost their networks, and as a result, we find that there's this discrepancy between the relationships you want. People who really had limited friends before are now realize how difficult it is to not have friends and to reassess the relationships again. So folks are not only alone, but they have perceived loneliness in terms of their difficulty. And then the whole descriptions of those kinds of symptoms that can lead to a major depressive episode. I just want to make the point that internationally, depression is recognized as one of the major disorders in terms of causing job loss, suffering, and distress. And yet, in many countries, it's still not recognized as such. I talked to a colleague from Nigeria who said, oh, we don't worry about it because it doesn't exist. There was a study in China that showed that many people simply would not describe the symptoms. Some of the cultures, it was inconsistent with the concept of being sad for no reason. And yet the symptoms are, when you ask people about their specific symptoms, the depressed mood, loss of pleasure, change in weight and appetite, is very much there. It's simply not recognized or it's ignored, even though it can cause a good deal of distress. And what we find is that because the pandemic differentially affects certain communities in the United States, African Americans, Latino are much more likely to report symptoms of anxiety or depression. Yet, what we know historically is that these communities in the US have often not had these symptoms as recognized, as even existing. And so the impact of the pandemic is more difficult and more stressful on low-income people, ethnic minorities in the US, but are less likely to be recognized as much more of as such of a problem. The problem of depression, anxiety are often misdiagnosed in the US. They're rare, thought to be rare in many of these communities. And because of this, social services that are associated with addressing these tend to be low. In addition, there's also problems of limited housing options, low income, and many folks, unfortunately, especially recently, live in areas in which the crime rate has gone up. And so this contributes further to the sense of isolation and ability to interact with others. And then, for me, I think with the concept of post-traumatic stress disorder, the experience of combat veterans who have long-term effects, and what we now recognize is that especially children in high-risk areas, as well as folks who are going through the coronavirus episodes, also developed frank post-traumatic stress disorder. Had a patient who was on a ventilator for a month. And when she came out, she had been indistinguishable from a combat veteran who had been sitting in a foxhole for the same period of time. One of the important points is by a former Surgeon General, Dr. Satcher, is that he did a large-scale study in the US showing that, interestingly enough, there was no significant difference across race, ethnic groups in terms of most mental disorders. What there was a difference was in terms of the burden because of lack of access for resources. And unfortunately, the coronavirus is replicating what he found. That is, again, we're running into problems in which we're finding certain groups have less resources. And because of problems like post-traumatic stress disorder, folks do not get the support they need. Now, what we're already finding is that many people find their symptoms exacerbated because of conspiracy beliefs. What happens is that folks literally spread fear for no adequate reason and without evidence. There's some folks who said that the virus is in fact attempted by large governmental bodies to inject some sort of controlled substance. There's belief that aliens may have been caused the disorder. And unfortunately, these kinds of conspiracy beliefs limit folks' willingness to seek help from professionals. But it also makes their situation worse because they now see it as perhaps there's some overriding factor that's making the virus not only spread, but also impact their community. Folks get some ideas that everyone is happy but me, the belief that this will never end, that it only affects certain groups of people. These kinds of beliefs, again, interfere with getting help, support, as well as addressing the needs. And the large question that Dr. Harris addressed excellently is, are services available? In the US, we find huge disparities across racial, ethnic groups in terms of mental health and substance abuse services that we frequently think quickly about providing sources of support for physical problems, but often there's little left to provide mental health care, substance abuse care. The US is going through a reduction in psychiatric beds. With the pandemic, the problems worsen because of folks needing beds for other kinds of problems. So a large issue is we know that you're facing an increase in mental health, substance abuse services going into the future. But the question is, will you be able to provide those services for folks who do not need direct hospital beds? The problem right now in the US is like 20% report distress, but do not have services for mental health or substance abuse. It is worse in certain communities, especially rural communities, some inner city communities, and raise the question of what are we going to do to address those needs? Some of the answers I think we're beginning to emerge. One positive of the pandemic could be that it's helped us to identify resources that we hadn't taken advantage of before. One is to preserve our social institutions that we already have using technology and thinking out of the box. The church informal gatherings have been very, very effective in terms of encouraging people getting treatment, in terms of getting personal support when governmental resources simply aren't available. And also, we begin to use community organizations to promote the kind of the kind of management to reduce some of these disparities. And Dr. Harris knows we got to expand our service providers. We're well aware in the US that there is a shortage of mental health providers. Internationally, the shortage is substantial in Latin America, in many African countries, where you have maybe 1 or 2 professional providers for 1 million people. It's extremely difficult to be able to address problems like depression and anxiety, which there's strong cultural beliefs saying that those kinds of problems do not exist and we shouldn't put a lot of resources to them. We need to be prepared and learn from the past for the next time. With the global warming, with biologics leaving tropical areas, there may be other episodes. And we should try to recognize that we had a warning, if you will, in the 1918. Now it's here. We need to build on that to prepare for the future. And one of the preparations need to be to recognize there will be a need for mental health and substance abuse services. So we got
Dr. Lawson, I'm going to ask you to wrap in the next minute or so, please. Thank you.
Yeah, I'm finishing now. So we got to look at the institutions that are helpful and are necessary for the future. So a lot needs to be done, but the promised land is, I think, is in sight.
Dr. Lawson, thank you so much, as always. Excellent, informative. Please stay around for some questions. And we're going to go ahead and move to Dr. Edwin Chapman. Dr. Chapman really personifies a point that was made earlier with respect to the integration of cross-behavioral health and general health care. Dr. Chapman is a mainstay in Washington, D.C. with the work he does in substance use disorder, and a resource across the country in presentations, education, training, and just letting folks know what's actually happening across the country with respect to substance use disorder. Dr. Chapman, can you please join us and speak to us?
And thank you, Dr. Walks. So I feel comfortable as an internist on a panel surrounded by world-renowned psychiatrists, but I'm going to do my best. So I had the honor of participating with on a panel for the American Medical Association chaired by Dr. Harris. But I was invited back to Howard University to participate in really developing some of the things that she was talking about, and Dr. Lawson is integrating primary care and mental health. As you know, we are a siloed health system, and mental health has been separated from primary care. And now we know that that was a mistake. So as Dr. Lawson has pointed out, shortly after the George Floyd incident, we saw this dramatic increase in depression and anxiety within 1 week. This was reported by the CDC in African Americans. So we have to talk about toxic stress. And this is a definition by Dr. Gabor Mate a number of years ago, really showing the impact of stress on one's ability to function. And it starts in childhood, and some say that it starts actually in the womb. So we have a history as African Americans of 402 years now of a very painful emotional history in this country. And so that painful history has become transgenerational trauma. And a couple of weeks ago, the American Medical Association put out a document talking about how should clinicians address a patient's experience of transgenerational trauma. That's what we're dealing with. In the short term is racism. So several years ago, Dr. Ayanna Jordan wrote a paper at Yale University really talking about the role of substance abuse in the African American community. And unlike the white community, the new epidemic, our epidemic generally started with street drugs. And we were self-medicating anxiety and depression. And that's been the history. So with the advent of COVID, of course, we've seen an increase in opioid overdoses, alcohol purchases, and this simply shows the dramatic increase in the past 12 months in overdose deaths related to opioids. And you can see from the diagram that the darker states actually indicate the highest incidence. And this is a picture of 30,000 fentanyl pills imported from Mexico that were seized a number of years ago. So fentanyl has now become a major source of the epidemic. So when we talk about the epidemic, frequently you hear people talking about the white epidemic, the suburban rural epidemic, being in 3 phases, starting with pills, then transitioning to heroin, and then transitioning to fentanyl. But the Black epidemic has been in two phases. We always started with street drugs, starting with heroin some 50 or 60 years ago during the Vietnam era. And so our transition was from heroin to fentanyl. And we can now see that traversing the country, that fentanyl, indicated by the red arrow, is the major source of the opioids, and a decrease in heroin and pills because of changes in the government. So what we see in this slide on the right-hand side is the dramatic increase over the past 12 months during the COVID pandemic, for all of the reasons mentioned above by Dr. Harris and Dr. Lawson. So here we can see that the District of Columbia, because it's a city state, so to speak, had the highest percentage of increase at 60%, which is somewhat deceptive because we don't have the dilution of the rest of the state. It's a city. And what we now know is that, particularly in our urban centers, that fentanyl over the past 5 or 6 years, particularly in the District of Columbia, has gone from 20% to 94%. So our patients are dying from not heroin, but and not pills for the most part, but 94% fentanyl in the street drugs. And we can see this again. We're 46. The Black population in the District of Columbia is only 46%, but we're 84% of the opioid deaths. And this pattern plays out in many urban settings: Philadelphia, Chicago, the same pattern. When we look at the national epidemic, we can see, if you look at just the predominance of overdoses are in the age range of 30 to 49. But in the African-American community, particularly here in the district, our patients are 59 to 69 because of that transition from heroin to fentanyl that I spoke about. So now this epidemic of fentanyl is spreading across the country. And because of the multiple forms, the fact that it can be liquid, powder, and these fake pills they call M30s that look like Percocets are really fentanyl. But we know in a survey that we did under the leadership of Dr. Lawson a number of years ago, that 42% of our patients surveyed required or asked or said that they needed behavioral health services that they were not able to get. And as Dr. Harris pointed out, there is a shortage of mental health providers in our community. We're only 5% of physicians, 4% of psychologists, 2% of psychiatrists. The other problems are related, of course, to the social determinants of health. Housing is a major problem. And in the district, like many urban settings, we're seeing a rise in homelessness. And that homeless population, we can see, was dramatically impacted in COVID. So 5 years ago, we had about 23 deaths in the undomiciled. Last year, there were 73 deaths. So that's a 200% increase in overdose deaths from opioids in the homeless population. And of course, with the winding down now of these support services for homelessness and food services, we're going to see another dramatic increase in a month or two. So we look at this epidemic in the African-American community, and we have to call it the cycle of despair because it's not talked about. Our medical community many times has not stepped forward. We had family and community ostracism, government apathy, inequitable insurance, And of course, our patients were incarcerated by an incentivized prison industrial complex. And all of this with underreporting by the media. This was well documented by Michelle Alexander. And so now we're seeing the results. During the pandemic, drug overdose rate has soared among African Americans, but it's not really talked about. And we can see again that we have three major medications that we use to treat opioid addiction: buprenorphine, methadone, and Vivitrol. But we can see that historically, African Americans were directed more towards methadone clinics, which are highly regulated, as opposed to buprenorphine, which was an office-based medication. And we can see that in a recent study, only 2.7% of buprenorphine prescriptions were prescribed to African American patients. So we're suffering from that. In November of last year, in the Federal Register, there's a push to expand buprenorphine treatment, and reportedly an untreated patient costs just from a healthcare cost $42,000. With treatment, the treatment costs $7,500. So you can see the dramatic savings that could be obtained with treatment. So we have a lot of pushback from the healthcare industry, particularly the insurance companies, because much of the savings from treatment of opioid addiction is what we call wrong pocket savings. It saves in the social service system. It reduces criminal justice, but those are savings that the insurance company does not always benefit from. So we have to develop a system much like the Ryan White system for AIDS, where we take knowledgeable specialty network money and then create an economic system that really supports the medical, social, economic, and judicial needs of this patient population. So I call that the cycle of repair, which means that it's going to take the entire community. We need advocacy, not only from the community, but also from our legal partners, medical support, of course, with medication-assisted treatment, because there's a 90% relapse within 100 years, within 1 year, if these patients are not treated with medication. We need individual and community education, housing, food, clothing, and financial support. So we presently have this system of mass incarceration, and we have to reverse engineer that system to community reintegration. And that's what this is all about. And this is just simply a schema that shows from Narcan resuscitation, really indicating the various steps that we have to educate the community on: needle exchange, safe injection sites, but that's only the pre-treatment component. We're currently using jails and sometimes residential treatment, but medication-assisted treatment is the standard of care. And when we look at all of these in a algorithm, we really have to understand that this is part of what we call a harm reduction model. And in that harm reduction model, even though it's not perfect, we are trying to reduce the chances that this person will overdose or die, reduce the chance that they'll get an infection that they spread to the rest of the community. And we want to integrate that care into a so-called one-stop shop, because these are often challenged patients. So Dr. Lawson and I have spent a lot of time doing webinars and educating in the community. And we start with the faith community. And we can see from this picture from Second Baptist Church in 1848, the pastor on the right side holding the Bible, but he's surrounded by what I would assume to be Union soldiers. So our folks were willing to fight and pray at the same time. And that's what we have to do now. We have to fight for our community. And this is an actual picture. You'll see Dr. Walks on the left-hand side, Dr. Lawson came to the meeting. He wasn't there yet, but this is a combined meeting of psychiatrists, community activists, and the faith community, all in one setting over a year ago. So we anticipated this problem because we knew we had a problem. And that has really been converted, particularly in the District of Columbia, to funding to over 25 churches to really promote education in the community. And these are the steps that are used. We've used a combined didactic and musical concerts to get our point across, to reduce and educate the community, ending stigma and myths. And this is now being formally introduced by Dr. Jordan at Yale University with a project integrating substance abuse in a church setting. So when we look back at our patient, after prison, more punishment, what are we going to do? We have to integrate drug treatment, mental health, and primary care into a single setting. And this slide simply shows how we're working with Dr. Lawson, Dr. Walks, to create a telehealth integrated model that covers all of these services. In other words, if I'm seeing a patient in my office for a substance abuse problem, we have the technology to bring in a psychiatrist without physically moving the patient. We have to make it patient-centered. And this is just a schema of how that would look. We incorporate the faith community for peer navigators and support services, food services, housing, et.c. So I'm going to stop there with the realization that 10 to 20%, only 10 to 20% of our health outcomes are related to what we do as medical professionals. 80 to 90% of our health outcomes are related to the community. So we are bringing the community into healthcare. And thank you.
Dr. Chapman, thank you so much for sharing your expertise with us. I feel honored to have been in one of those pictures. It seems that you know everyone, but then I knew that. So we want to get to a few questions for our panel. I know that Dr. Harris is going to have to leave us in a few minutes. Dr. Harris, you mentioned earlier that many of our colleagues are having challenges during this time. How do we reach out to our colleagues? How do we make it okay for the doctor to say, I need a doctor?
Thank you for that, and a great question. I do, and of course, always honored to be on with Dr. Chapman and Dr. Lawson. I love what Dr. Chapman said. He said, fight for right. And part of that is advocacy. And he also mentioned that. So I think that's part of the issue, because the model that he just elucidated, and someone even asked, how challenging is it to do this in a 20-minute visit? We know that. And so we are going to have to reform our payer system and look for alternative payment models and get the next generation of legislation to support these payment models that you just saw. And so, and by the way, with the relaxation of the rules regarding patients, physicians treating patients with buprenorphine, you can treat up to 30 without going through the waiver. The AMA actually supports total elimination of that, not training, but just a new way of not education, of course, but a new way of looking at that. So we encourage all of our primary care colleagues to follow Dr. Chapman and, become and be willing to become buprenorphine and provide that as a service in your office. How can we help our own? I think we have to certainly have that proactive approach, right? There are a lot of external issues. We have not made it very easy in our country for physicians and other health professionals to seek help. When you have to answer a question on your licensure application, have you ever been treated for a mental disorder? And we know what happens after that. Now, fortunately, those are changing, but there is still a lot of stigma. So we have to routinize that, right? And we have to start actually in medical school. And we have to make it routine and we have to be proactive. And so I know during COVID-19, a lot of very well-meaning systems, and this was good, sort of had this pull. So, okay, doctors, nurses, therapists, if you need us, we are here. And that's fine, but it has to be also, let's have a huddle after every shift. Let's make that a routine piece so that folks don't have to even go to seek out services. Let's make sure that we make it routine to talk about these issues, talk about stress. There are buddy programs, and that's not peer review. That's just buddy, someone that you can talk to about today was a horrible day, and I'm really stressed. And so I think there are a lot of things to do. I'll just commend for any, especially system out there, because remember, burnout is not physician heal thyself, right? We're beyond that. We need systemic change, right? Because I can eat right and get rest and get and do yoga and do all of that, which is good. I can do what I need to do, pray to stay healthy. But if the system doesn't change, then that won't help me. And so everyone out there listening, you know, our systems have to make sure that they have opportunities in place and promote help-seeking opportunities in their large systems.
Thank you so much, Dr. Harris. Dr. Harris, I know you have to run in about 1 minute, so thank you again for being with us. It's always a pleasure, and I guess the reason it's a small world is so all the good people can find each other. You and Dr. Lawson and Dr. Chapman have been able to work together. It's just a wonderful thing to know that. Let me ask Dr. Lawson, you made a comment earlier and talked a little bit about the impact of the mental health challenges on jobs and on people, on the economics in the community, and that dovetails with an earlier presentation. How do we help people identify and maybe even help them communicate with their employers that the mental health issues may be impacting their work performance or their ability to actually get to work?
Yeah, that's an excellent question, because what I found is that, in fact, in many jobs, in terms of the patients that I've worked with, that the job itself, the employees recognize when there's a problem, but they often don't really have any way to deal with it. They may have an individual who is employed, and there's a conflict of interest, because the person says, well, I'm suffering, what can I do? And the employer may say, well, take some time off. But what we found is that many people of color are in situations where taking time off means taking money off, and worsening the situation that they're in. And the second thing is that it also impacts job performance. Very rarely have I found that employers knew how to take into account depression and anxiety as factors in terms of why a person's performance may not be optimal. So rather than looking at those as identifying problems, it becomes a punitive process. So what we need to do is take the punitiveness out of it, educate employees, educate, and recognize that these are conditions, as Dr. Chapman notes, it ties all together. These are conditions that are illnesses, just like having the common cold, just like having the flu, and they are illnesses that should be given consideration for treatment time away from the job so that they can come back and be as effective. The brain fog problem is a big one because many times it's not recognized as an illness and is also looked at as a way for a person to shirk off and put other work on other individuals there. And right now, I'm seeing very few clinical trials or treatment interventions to address those problems, and yet they have to be addressed so that people can be productive. In addition to that, we have treatment for depression and anxiety. But what we're finding is that many people are afraid to ask for them or are seen as stigmatizing for the direct workplace.
So Dr. Lawson, thank you so much. These are all so very important points. Dr. Chapman, you talked about toxic stress and that leading to so much of the opioid use increase and overdoses. But I think that sometimes people don't even know they're getting fentanyl, right? I see patients who say, well, I don't know, this popped up in my drug screen. I wasn't taking fentanyl. And the not knowing you're taking fentanyl can be a real problem. So please address that. And then real quick, what about the folks that don't die from an overdose? How much of an impact is it on someone's life to not know you're taking a deadly drug, find out you're taking it when it almost kills you, and then trying to put your life back together?
So you're absolutely right. I didn't show the slide that really shows that a lot of the overdose deaths, a certain percentage, are combinations of drugs. And in the African-American community, it's frequently cocaine and maybe even marijuana or K2. That because fentanyl can now be woven into the drug supply, sprinkled on or sprayed on, that you're buying one thing and getting something else. So to answer your second question, with the 94 or 95% tox screens that we're now getting in the District of Columbia, and I think that's the highest in the country, that patient, as far as I'm concerned, is a Darwinian survivor. The fact that they came in the office with an opioid problem, I know that they must be an ultra rapid metabolizer of fentanyl because they're alive. Those who who die or overdose and never make it to the doctor are probably slow or intermediate metabolizers. So we have a chance to really treat that person. And really, the key is to intercept or to treat during these transitional periods. If you have a patient who's currently using pills, you have to get them on medication now, because when they make that transition from pills to street drugs, whether it's heroin or fentanyl, their chances are we're seeing the results. We're seeing the fact that a lot of these folks are not getting a second chance.
So Dr. Chapman, Dr. Lawson, we are out of time, but I am not out of questions. We have questions in the chat and comments in the chat. A lot of folks are really focused on the issue of racism and how that impacts all of the things that we're talking about. Differential seeking of help, the whole prison industrial complex, Dr. Chapman, that you mentioned, those questions are left in the chat. We're going to try to get back to a lot of that as not only as we finish up this symposium, but as we go through many of the Black Health Trust programs. These are things that are so impactful in all of the communities that we frankly care about. We are supposed to take a little 5-minute break now. So why don't we go ahead and do a short break? And I'm going to take moderator's prerogative and have us go to a 4-minute break, just so folks have time to stretch, maybe click on a couple of voicemails, and then we're going to come back with the lovely and talented, the amazing Dr. Barbara Neighbert-Stevens. So 5-minute break, everyone. Thank you. 4-minute break. Good afternoon, everyone, and good morning to some, and welcome back to all. This is Dr. Walks, and thank you so much for being with us today. I would like to introduce Dr. Barbara Nabrit-Stevens. All of the bios of everyone, all the presenters, all the moderators are available online. What's important for you to know about Dr. Barbara Nabrit-Stevens is that she is a pediatrician extraordinaire with all the right Harvard credentials and all of that, but she really cares about people and cares about all the communities that we serve. So Dr. Nabrit-Stevens, please take it away.
Thank you so much, my friend and colleague, and welcome back, everyone. For those of you who have been with us since the start, this has been such an overwhelming meeting. We have had so much stimulating, thought-provoking ideas thrown at us and a charge of work for all of us to do. I want to let you know that we're still at work. This session is going to focus on cardiopulmonary burden of long-haul COVID. And we're going to start off with a presentation from Dr. Kevin Alexander, who is an assistant professor of cardiovascular medicine at Stanford University Center in California. He is an advanced heart failure and transplant cardiologist and also conducts basic and translational research for cardiac amyloidosis and other forms of heart failure. He's going to lead us in a discussion now on myocardial infarction and heart failure. Dr. Alexander?
Great. Thank you, Dr. Nabrit-Stevens, for the kind introduction, and to the organizers of this event for the opportunity to speak to you. I'm going to talk to you about the cardiovascular considerations for long COVID-19 syndrome. I don't have any, these are my disclosures. I'm not going to talk about any specific therapies or off-label medications today. So I want to start off with a case to kind of put into context, at least my experience with dealing with COVID-related cardiovascular complications. So I'd like to rewind back to earlier in the pandemic, in the spring of 2020. This was a patient I took care of, a 61-year-old woman who presented with sudden onset chest pain. She had a medical history of controlled hypertension and type 2 diabetes. And she had been treated had a COVID-19 infection 3 weeks prior to this chest pain presentation. Her symptoms were mild, just a little bit of shortness of breath, and she was managed with supportive care at home and quarantining. So quickly after her presentation in the emergency room, they did an ECG, which showed anterior ST elevation myocardial infarction. Coronary angiography showed a total occlusion of the left anterior descending artery. And the appearance on angiography was that of acute thrombus. So rather than a plaque rupture myocardial infarction, this looked to be more thrombotic. And so the patient underwent thrombus removal and stent placement. So I wanted to just talk, briefly mention some of the acute changes that we've seen with COVID-19 infection. I think this is a nice graphic that shows kind of what can happen over the initial few weeks. So we know early on in the disease, there's the viral replication phase, and that leads to symptoms that you've heard about with fever and malaise. And a subset of patients would go on to develop pulmonary symptoms. And the ones that had a lot of morbidity and mortality, the ones that end up being hospitalized and having severe COVID infections, are ones that have a robust host inflammatory response. And this happens 2 to 4 weeks after those initial symptom onset. So what does that look like from a cardiac standpoint? Well, we see evidence of cardiac injury, like elevated troponin and NT-proBNP. There can be elevations in thrombotic markers as well as general inflammatory markers. And how that manifests in terms of cardiovascular disease, you can see myocardial infarction, like in the patient that I just presented. We can also see decompensating heart failure, myocarditis, and other thrombotic and vascular inflammation. So while that case was a very dramatic presentation, unfortunate that that was the only case of that I've seen during this pandemic of an acute myocardial infarction like that. Now I'd like to give a presentation of a case where I've seen several examples of this over the last several months, and I think that fits into the theme of long COVID syndrome. So this is a 24-year-old gentleman who I met who had had several weeks of exertional dyspnea, chest pain, and palpitations. So he had had a mild COVID infection 6 weeks ago. And he, part of it, his social history, he's an avid runner, loves half marathons and triathlons. And after he's gotten COVID, he hasn't been able to get anywhere near back to the exercise capacity that he enjoyed prior to the infection. So we did a cardiac evaluation, which was pretty unremarkable. His ECG showed sinus rhythm with no evidence of ischemia or pericarditis. His labs, including cardiac biomarkers, were normal. He underwent a stress echocardiogram. And so while there are no ischemic changes, the thing to highlight is that he only exercised for 6 minutes on a standard Bruce protocol, which for a 24-year-old, particularly a fit 24-year-old, should be able to do much more than that. And so this really highlights the gives an objective measure of the functional limitations that he's had since the infection. So we're still learning what some of the prevalence of cardiovascular symptoms in patients with long COVID syndrome. And we're getting more observational data coming out over the last several months. This study that I show here is from JAMA Network Open, where they did a systematic review of, I think, over 26 observational studies looking at symptoms in people with persistent COVID, which they characterize as people that had symptoms 60 days or farther out from their initial COVID presentation. And I just highlight some of the cardiac symptoms. People can have atypical chest pain, shortness of breath, palpitations, exercise intolerance. You can see from their from the systematic review, we know that there's a high prevalence of dyspnea and fatigue, somewhere in the 30 to 50% range. And certainly that can be multifactorial. I don't want to imply that it's all cardiac related. But you can see that atypical chest pain and palpitations have a not insignificant prevalence, around 20%. And so it's something that I think a lot of patients will end up encountering. And so we need to understand this better. So the mechanisms linking COVID with these cardiac symptoms are poorly understood, and definitely an interest of mine and others to further elucidate that. I think there's been some interesting proposals about how the intersection between these two conditions. Shown here is a nice review looking at long COVID and heart failure. So we know that with COVID infection, particularly those that have moderate or severe COVID infection, they can have hypoxemia, acute respiratory distress syndrome, systemic inflammatory response, and hypercoagulable state. And these factors tend to be worse in people that have underlying cardiometabolic disease, such as hypertension, dyslipidemia, coronary artery disease, and diabetes. And a lot of those factors are things that can exacerbate or contribute to heart failure, particularly heart failure with preserved ejection fraction. So hypoxia can lead to right ventricular dysfunction, pulmonary hypertension, and the cardiometabolic risk factors and inflammatory conditions can lead to particularly diastolic dysfunction. So I think there's probably several complex interactions between things that drive chronic COVID complications and can potentially exacerbate heart failure. And so this is an area that needs to be investigated further. Another interesting area that's come up is long COVID in athletes. Particularly we've seen in college sports and the NFL, and now the NBA, when athletes have COVID, there's a lot of protocols they have to go through to make sure it's safe to return to competing. The biggest concern is probably related to myocarditis, inflammation of the myocardium that's been associated with COVID-19, and certainly extreme exercise can exacerbate myocarditis. And so, in athletes, it's a particular worry that they go to back to competitive sports too early. That could lead to significant cardiac damage. So this was the figure shown here came from an expert consensus statement proposing strategy to screen and evaluate athletes for signs of myocardial damage. And so a lot of it's similar to, a lot of what they propose is similar to the case that I presented earlier. I think screening initially with ECG and cardiac biomarkers to look for injuries, kind of a first kind of 30,000 foot view. And then the echocardiogram will provide a lot of helpful information because you'll be able to see signs of ventricular dysfunction, left or right ventricle, as well as signs of pericardial disease or effusion. So, they propose if all those things look completely normal, that the likelihood of significant cardiac disease from COVID-19 is low, sufficiently low, and individual can go back to the competitive sports. If any of those things there's concern or abnormalities, then further testing such as cardiac MRI to get better tissue characterization of the myocardium, or other tests like exercise stress test or cardiac CTA in some cases to look for coronary artery disease might be indicated to better elucidate what cardiac abnormalities are observed in this initial screen. So, at least to me as a cardiologist, that seems like a straightforward algorithm at first blush, but I think in practice, it's definitely more challenging than that diagram that I showed you. And part of that challenge is because athletes, competitive athletes can have cardiac changes associated with an athletic heart that can look like pathologic disease. And an example that is shown here. So I show you two ECGs. One is from an athlete who's asymptomatic and healthy, and the other is from someone who had an athlete who had COVID-19 infection and had evidence of pericarditis. So I'll just pause for a second and see if people can pick out which one is the abnormal one and which one's normal. And just to describe the ECGs, they both have sinus rhythm with voltage criteria suggesting left ventricular hypertrophy. And you can see with the blue arrows that there's evidence of diffuse ST elevations. So, I would say based on just the ECGs alone, one would not be able to distinguish between the healthy athlete versus acute pericarditis. And so if I give you more clinical information, the one on the right is the pericarditis, and that person had an elevated troponin and subsequently had abnormal cardiac MRI consistent with myopericarditis. So I think the important thing with assessing athletes or anyone that you're suspicious of having cardiac disease related to COVID is to take all, integrate all the cardiac data to come up with the diagnosis, because one data point probably isn't sufficient to risk stratify these patients. So what are some of the tests that I pursue and others when looking at patients where they might have cardiac related symptoms due to long COVID? Certainly, the symptoms I show here in the suggested test, there's some overlap. So I don't want to portray these as being mutually exclusive, but it's on a shortness of breath. The key thing is really distinguishing between a cardiac versus a pulmonary cause for their exercise intolerance and dyspnea. And so lung imaging early on is important, as well as an echocardiogram to screen for disease in those two organ systems. In a few cases, I found it's helpful to get cardiopulmonary exercise testing, where you're measuring VO2 as well as other exercise parameters to really help distinguish between how much of this is pulmonary versus cardiac. Many patients, like I showed from that systematic review, can have atypical chest pain. So you want to do cardiac biomarkers in ECG to look for myopericarditis or signs of ischemia. Cardiac MRIs can be very helpful in this scenario. And if there's any concern for coronary artery disease, a CT angiogram can be a non-invasive way to screen for either coronary anomalies or stenoses. And another kind of subgroup of patients with long COVID cardiac symptoms are those that have persistent palpitations. Those can either be due to arrhythmias such as supraventricular tachycardia, atrial fibrillation, and so a cardiac monitor would help to pick up those abnormalities. There's also there's some patients that will develop kind of an orthostatic palpitations with the orthostatic component. And this disease presentation is very similar to a condition that we already see, postural orthostatic tachycardia syndrome, or POTS syndrome. And so that's a condition that has related to dysautonomia. And so one thing to consider if you have someone with that kind of potential syndrome is to consider tilt table testing to elucidate that out better. So some of the things to consider for interventions at this point, anyone that has ongoing exercise intolerance and you've ruled out myocarditis, I think it's reasonable, or active ischemia, it's reasonable to refer to cardiac rehab. If someone's having persistent chest pain despite conservative interventions, you can consider anti-anginal therapies that we would use for patients with coronary artery disease or microvascular ischemia to see if that helps. And then for palpitations, certainly if the cardiac monitor picks up a arrhythmia, treating that as appropriate. And if the cardiac monitor is unrevealing, then considering treatments for POTS syndrome is reasonable. So that usually relates to ensuring adequate fluid intake, as well as sodium intake as well. And on top of all that, I think it's important to mention that it's in general, I think that one thing not to forget is any kind of modification of traditional cardiovascular risk factors. So controlling hypertension, diabetes, obesity are important things to consider and shouldn't get kind of lost in the evaluation of these other signs and symptoms. So we're still learning a lot about cardiovascular complications related to long COVID-19. So it's an interesting area for research. Some of the questions I think that need to be evaluated further are ultimately what's the duration of these cardiovascular symptoms? We know that patients can have these out for months, but beyond that, do patients gradually return to normal function or have ongoing symptoms that last longer? Remains to be seen. What is the risk of future cardiovascular events, myocardial infarction, stroke, et cetera, in people that have had COVID-19 infection? And is it different for people that had kind of a short presentation versus long and persistent symptoms? And then with the emergence of vaccines and pharmacotherapies for COVID-19, do any of these mitigate the risk of long COVID cardiovascular complications? So thanks for your attention and look forward to chatting in the Q&A.
Thank you so much, Dr. Alexander. You touched on a lot of points that I know have intrigued a lot of people as we have made this journey in the pandemic. Our next speaker is Dr. Tony Wang. Dr. Tony Wang is the director of the Stroke Center at Maimonides Medical Center in Brooklyn. He is a vascular and interventional neurologist and an associate professor of clinical neurology at SUNY Downstate. Now, Dr. Wang is going to talk with us about something that has gotten a lot of press attention for sure, cerebral vascular accidents. Dr. Wang?
Thank you. Thank you for the kind introduction, Dr. Nebrit Stevenson. I'm really honored to be here to be among the esteemed speakers, and also thank you for the invitation to talk about this important topic. I'm a stroke and interventional neurologist. I've experienced the care of the stroke patients infected with COVID and impacted by COVID during the pandemic. So let me share my slide and to talk about the impact of COVID on the stroke. I have no financial disclosures. Basically, I'll just briefly overview the COVID-19 pathophysiology, symptoms, diagnosis, and treatment prevention before I go on to talk about factors potentially affecting the COVID-19 infection and mortality rates from a different perspective from the speakers previously presented. And also I'll touch upon COVID-19 CNS central nervous system involvement, including anosmia that many of the audience are having questions and interest about. And COVID-19 impact on stroke and volume and subtypes will be followed in addition to Maimonides Stroke Center comprehensive stroke program local experience in COVID-19. I wanted to say that we're very proud to be one of the comprehensive stroke centers in the nation has the lowest stroke mortality rate. However, we were significantly impacted by the COVID pandemic. You don't really need me to tell you more about the enormous devastating impact of COVID pandemic on the global health and socioeconomic status of the humanity over the course. Suffice to say that there are many areas of the globe affected by this global pandemic that are having different mortality and morbidity risks and manifestations, infections. So a couple quick word on the pathophysiology, diagnosis, and treatment. I think many of you have read and heard experts in this area, so I won't dwell too much on this. Suffice to say that the average symptom onset from the initial infection is about 5 days, with more than 97% of patients will become symptomatic if they become symptomatic within the 2-week period. And more than 80% of patients are actually, fortunately, having mild symptoms. And it is truly a multi-organ disease process besides the pneumonia, just as mentioned previously, including the heart and the brain, including the stroke. About 5% of patients will be hospitalized, and 75% of patients hospitalized will require oxygenation. The average mortality globally is about 2%, but it's highly variable, depends on age, comorbidity, and other factors, which I'll touch upon later on. And there's different variability in terms of the detection method and specificity, which also led to these the belief that more than 5-fold of true infections are actually out there than the ones that are presenting with symptoms or detected. A quick glance at the COVID mortality, so-called mortality to incidence ratio across the globe. You see a large variation of both at different areas, different countries, different continents. But suffice to say that we all know with definitive that many protective measures such as face masks, social distancing, contact tracing, hand hygiene, definitely reduced infection and mortality. For example, in East Asia countries where the population has a much more homogeneous compliance understanding of these importance, and they were able to actually limit both the infection rate and mortality rate to a minimum, despite very high population density, such as in Taiwan. I was shocked to find out that even though as the early epicenter of the US COVID pandemic, New York City, 4 counties out of New York City actually lead the country for accumulative mortality, which is highlighted in blue bar, whereas the relative infection rate has been roughly comparable to the rest of the country. And besides the 4 boroughs out of the 5, other than Staten Island, all of them actually had a very high mortality rate. The 2 of the Long Island counties, Suffolk and Nassau counties, also was among the top 20 counties by geographic area. Now, if you compare the top county, which is Kings County, where our home institutions, Downstate, Maimonides, and Kings County reside, we have the highest number of mortality rate, which is about more than 6-fold higher than the number 20 Salt Lake, Utah. And there are many reasons that contribute to this difference in geographic area. One potentially is population density. The other one is other factors I will talk about in the next slide. However, I think one more important factor contributing to this phenomena is the early epicenter in New York, as we are still struggling to understand, to deal with this new virus, and there's capacities for our healthcare system at the time. So if you take a deeper dive into the a deeper dive of the many characteristics, or including demographic differences between these two counties. We'll start with the Salt Lake County, which is ranked number 20 in terms of COVID pandemic mortality. You can see the population is much more homogeneous. 80% of them are actually whites. And there's a relatively small percentage of people who live in underneath the poverty, using Medicaid as their primary access for healthcare system. And in terms of older population, more than 65 years old, they have about 10% of population, which we know older population tend to be affected much more severely with higher mortality than the younger population. And if you look at the total hospital beds by per thousand population, it's actually fairly comparable to the Kings County in Brooklyn. However, if you look at the ICU beds, actually they have a much higher rate of almost double the capacity. So this is a summary of the numbers I just mentioned between Kings County and also the Salt Lake County. You can see we are about 6-fold higher in terms of mortality than the Salt Lake County. And these are the risk factors potentially associated with the high mortality, including age, socioeconomic status, access to care, especially the ICU level of care, where even though we have higher, twice the population, but we have less of the ICU beds. So race, age, socioeconomic status, and access to care may contribute to increased COVID-19 mortality. If you look at the ICU occupancy across the country during this is the second peak of the pandemic from September to May, you can see the ICU occupancy by the COVID population, as highlighted in orange, did correlate with the infection rate and rise in early January and February, whereas the non-COVID ICU patients remained relatively stable. We do have actually actual ICU capacity as actually marked in gray. So it's a matter of how to distribute these resources across the geographic area and also the population differences. And in New York, this is New York State. We enjoyed a relatively quiet, end of last year for COVID infection, but we also seen a similar rise of the COVID peak during the second phase in early January and March of this year. So I'm going to switch gear to talk about the central nervous system involvement with COVID. I really like this article by Sutarter et al. In Journal of Neuroscience, Journal of Neurological Science, which depicted the various ways of invasion of central nervous system by COVID virus. One of the ways is through the cerebrospinal fluid. There are about 6% of the samples they tested, actually, according to literature, tested are positive with coronavirus PCR, whereas 12% of samples are positive for antibody testing. And as high as more than 50% of the patient could present with smell changes such as anosmia, dysnosmia. Of course, hematogenous spread of the COVID is also an important route, especially when you have blood-brain barrier breakdown, such as in stroke or hemorrhage, so on and so forth. There are also proposals of neuronal dissemination that potentially can transmit between the nerve cells. The trigeminal nerve is one other potential access from the head, other than the olfactory nerve. So these are important potential pathways for COVID to invade the central nervous system. The symptoms of the common symptoms listed on the right can have actually, because of the neurologic manifestation of this disease, as listed over here in the middle. So as I mentioned, this is a meta-analysis actually looking at various reports of anosmia or lack of smell for patient population with different size of samples. And out of 1,600 people combined of all these studies, up to 52% of them could present with loss of smell, which has become a near hallmark of the COVID pandemic infection symptoms. What about stroke, hemorrhage, and so-called cerebral venous sinus thrombosis, which has gained a lot of attention related to the vaccine complications? So if you look at these different categories of cerebrovascular diseases, it varies from 0.1% to up to about 5%. Depends on the study population, the time, the geographic area, and population. And it's divided, most of them are counted by ischemic stroke, which is a type of stroke that causes decreased blood flow to the brain or stop the blood flow. Whereas intracerebral hemorrhage, the bleeding type of stroke, is far less. It's about 20% of the population. And venous sinus thrombosis is present, but at a much, much lower rate than the other categories. And stroke presentation can actually, after COVID infection, can present in different flavors, including large vessel stroke, which is the most devastating stroke that causing the highest mortality and morbidity. And this is one of the articles generated a lot of attention, public attention about COVID patients in a young population, published from the Mount Sinai group, where they've noticed their nearly 7-fold increase of these cases during that peak period of the COVID pandemic, first peak, more likely to develop these large vessel occlusions. So the mechanism of these large vessel occlusion could be multiple-fold, could be hypercoagulable state related to the COVID infection, sorry, and or the endothelial damage caused by the infection, leading to large vessel breakdown, the damage, causing secondary thromboembolic events. Of course, one thing we also look at is our local experience and besides ischemic stroke, also hemorrhagic stroke, which I'll touch on later on. So this is another type of presentation called acute hemorrhagic necrotizing encephalopathy. And patient had multifocal involvement of the brain. These are MRI studies looking at the brain. You can see the temporal lobe, medial temporal lobe were involved, the bilateral thalamus involved with hemorrhagic components in there, and some necrosis. Patient is comatose in this patient population, in this case. And what about hemorrhages? So we actually published an article recently in the American Journal of Stroke and Cerebrovascular Disease, between March of 2020 to July 31st, 2020, we totally had 65 intracerebral hemorrhage patients presented to the Maimonides hospital, which accounts to about 20% population. And among those, 11 of them listed over here had intracerebral hemorrhage, 9 of which had at least one comorbidities, and 8 were white, 70% of them had severe pneumonia, and the median age was about 70, whereas male was about 58%, and 2 of them were very young, less than about 30 years old. One of them actually was fatal, unfortunately, and about half of the patients were actually obese. So these are some of the risk factors potentially can affect the intracerebral hemorrhage COVID-infected patients with higher mortality rate. And if you look at the overall stroke admission and discharges at Maimonides, you can see between January of 2020 and to the end of the year, compared to the same period in 2019 as marked in blue lines, the orange lines are the 2020 data, can see there's about 50% reduction of admission rate during the peak of pandemic around April and March, compared to the rest of the period. And whereas you have a reciprocal rise of COVID positive stroke patients during the first peak in April and May, and then also during the second peak in January, February of 2021. And this is also a similar national trend. This is the guidelines, all hospital data from January of last year to April this year. You can see the similar trend. The part of the reason for this presentation, we think, is largely due to the fear of hospitalization or contracting of COVID during the peak pandemic. So people, actually, patients with milder symptoms are afraid of coming to the hospital for presentation, leading to a dramatic drop of ischemic stroke and TIA, transient ischemic attack presentations. So this is the our ICH data showing actually we have the highest intracerebral hemorrhage rate during, and also number during the peak of the pandemic. Up to 40% of that month there were intracerebral hemorrhage patients, and also the highest number. So stroke, by definition, is as the 5th leading cause of death in the United States, and the leading cause of disability. But then the definition is a long-term impact on patients' lives, because they often have residual permanent neurological deficits. And COVID infection certainly is no exception, will have impact on these patients, besides the many symptoms we have heard so far. So understanding the pathophysiology and interaction between the COVID infection and cerebral vasculature is important to better understand and treat to prevent this long-term and future infection and stroke symptoms. So this is a summary. I'm not going to read through this, which I've been talking about, and I'll stop here to take any questions later on.
Actually, we're going to hold the questions to the end, Dr. Wang.
Sure, thank you. That's fine.
Thank you. Now we're going to move to coagulation disorders, and Dr. Yogan Kante is going to lead us in that discussion. Dr. Kante is the Chief of Laboratory Vascular Thrombosis and Inflammation at National Heart, Lung, and Blood Institute. He was recruited there from the University of Michigan, and it's a good thing he was there, because with the COVID impact, he was recruited to mobilize a team early in the pandemic and is very involved in the COVID discoveries that have led to 10 clinical trials with drugs to lessen the impact of the pandemic. So without further ado, we will hear from Dr. Canty.
Wonderful. Well, thank you very much. It's an honor to be able to speak here and present in this very interesting and I think unique symposium that probably will be become a recurring annual symposium. So I want to thank Dr. Salifu, Dr. Maxey, and our host, as well as the session chair, Dr. Nabrit Stevens, for the kind invitation. I'll present to you today something that's a little bit of a different flavor than what we've been seeing so far. And this is a lot of our translational research into understanding why people with COVID are developing this thrombosis and thrombotic disorder that we've been hearing about in many of the other talks today, including Dr. Wong's talk just now. So I have one disclosure of an unrelated pending patent that is not owned by me, but I'm an inventor on it. And most of our work here has not happened in isolation. It has been the result of a large team that's gotten together. So I want to acknowledge their contributions, especially those of our patients who are willing to give their blood samples and participate in clinical trials in arguably the scariest time in their lives. And then finally, our funding sources, the NHLBI and the University of Michigan, without whom none of this would be possible. So this group is now, I think, fairly familiar that inflammation and coagulation are very closely related to one another. This makes a lot of sense to me from an evolution perspective. If you are walking in a jungle and you fall and you cut your knee on a rock somewhere, you've got to be able to stop the bleeding, and so you need inflammation for that. And then you also have to be able to heal the wound and also fight off any pathogens that may have entered. So you need an inflammatory response that goes along with it. And we know that there are some groups who are more prone to developing inflammatory complications. We know that there are certain ethnic populations and racial populations that can actually develop more of these inflammatory consequences. Of course, this is evident in when we look at population studies that suggest that East Asians have a lower risk of thrombosis than do Caucasians, and Hispanics have a higher risk, as well as Blacks do. And so we certainly know that there are some differences. This really does come out in clinical practice as well. Here's a picture of the coagulation cascade. This was the figure that made me most fall asleep when I was a second year and a first year medical student, but it has come back and become quite important. We know that in Blacks, at least in the US, there is an increase in the risk of venous thromboembolism that's significant. And what is highlighted in green over here are the various ways that we think the coagulation cascade is affected and upregulated. So there's a propensity to clotting that may be driven by some of these factors, as well as others, in particular in Blacks. In addition to that, we know that there is risk of arterial thrombosis as well, things like stroke that Dr. Wong just talked about, also myocardial infarction, which Dr. Alexander has spoken about. And our group had worked a little bit on identifying, it was Ben Trudeau's group who worked on identifying one of these genetic mutations or variants that can actually predict a higher risk of thrombosis and maybe resistance to some antiplatelet agents. And we know from some studies that his group and another have done in Utah that this variant is more disproportionately overrepresented in Blacks versus whites. So we're identifying that not only are there some physiologic markers that we're identifying, but in addition to that, there may be some genetic etiology as well. And so this certainly is true of what we've been seeing clinically pre-pandemic. And then there've been a lot of studies that have been done in the post-pandemic or during the pandemic thrombosis to understand whether disparities can make a difference in outcomes. You've already seen some information today that Dr. Dmisset and Dr. Benjamin presented on how minority populations are affected, have a twofold risk of hospitalization and almost 2 to 3-fold risk of death that's higher than in Caucasian populations. And so we do need to think about that. There have been a number of studies here that have been done looking specifically at thrombosis. This study that was published in Circulation Journal, which is from the American Heart Association COVID Registry, found that there was no increase in the risk of thrombosis that was based on race or ethnicity. This was an early report. It was about 6, 7, 8 months ago. Here's another report suggesting there may be no difference in thrombosis again. But this doesn't really feel right because we know that patients who are minorities are much more likely to get hospitalized and have worse outcomes. And so there's an article here that suggests that there may be more than meets the eye in terms of thrombosis risk. And we certainly think this may be true for a couple of reasons. One is that all the thrombosis that we see in patients is actually macrovascular, clinically apparent clots. But what we've learned is that COVID-19 clots actually are much more microvascular than macrovascular, and they result in organ compromise and organ failure. Those may not present on a clinical test. And so we need to think about those as being something that we look a little more carefully at as we start to make decisions about what, or do studies and presentations on whether there are race-related differences. Of course, we've seen this, that there is an increase in clotting. And so I think as a cardiologist, to think about blood clotting, I stop and I think of it in a very simple way. There is blood that's flowing in a blood vessel. You've got a number of different cell types in the blood. There are red blood cells that carry oxygen, platelets that we think about as plugging up bleeding holes to prevent hemorrhage. Then there are your white blood cells, things like neutrophils that are your first responders, monocytes, which we consider the cleanup crew. They come in and try to eat up things that aren't supposed to be there. And then lymphocytes, which present a memory to the immune system and can produce antibodies. And all of this is within the vascular system, which is lined by the endothelium. So when we think about how clotting happens in a cell-based manner, I present to you this cartoon where the endothelium can become activated. And when that happens, you can start to have expression of these cell adhesion molecules, and pay attention to that and keep that in mind. We'll come back to that later. And then you have leukocytes that start to attach to the endothelium. Monocytes can start to produce cytokines and tissue factor, which make blood clot. Platelets can become activated and start to plug up and aggregate within the blood vessel and start to form occlusive thrombi. And neutrophils would start to do a number of different things. And so our group has focused on a number of these aspects of blood clotting, and I'll just make a quick outline of what the talk here is going to be about. It's how neutrophils can form extracellular traps. Then a short discussion about prothrombotic autoantibodies in COVID. We'll discuss sickle cell disease for a moment, and then some clinical trial work. So neutrophils are the most abundant type of blood cell in circulation in the immune blood cells. They're fully armed when they're released into the blood cells, and so we typically have thought of them as being the grunts of the immune system. They are the first responders to infection, inflammation, and injury. And the human body produces about 200 billion of these cells a day. So there's a sizable amount of energy that our bodies have dedicated to generating neutrophils. And so their function, I'd suggest to you, is more than just a blunt instrument. They actually can be somewhat finely tuned methods to try and prevent infection, inflammation, and a few other things. Neutrophils have this really interesting thing that they can do. When they encounter pathogens, things like viruses or bacteria or fungus, they start to unravel their chromatin and they start to spit out their DNA from the side in a form of a suicidal net that starts to now trap bacteria and these other pathogens. And this is great, again, for when you're walking around and you've fallen and hurt yourself and you've got bacteria that's now entering your tissue. But if this happens in the absence of bacterial or viral infections, or if it happens in an unregulated form, in the blood vessel itself, it can actually start to trap other tissues. It can trap cells, it can be a scaffold for clot formation and coagulation, and eventually form occlusion of blood flow to that organ system. So we know that there are a lot of risk factors for net formation or netosis. We know that nets are associated with venous thrombosis. This has been shown by our group and a number of others as well. What I'll show you here is a picture of what a net looks like. This is not from our group, but I think it's just a beautiful illustration. The yellow is a neutrophil. The green is the sticky web of DNA that's extruded from the neutrophil itself. What you see in blue over there are bacteria that are being trapped by that net. So we've been thinking a little bit about why we weren't seeing reports of blood clots in COVID-19 back in February and March of last year. Certainly then we started seeing reports of sticky blood and this corona blood clotting mystery that seemed to be intensifying. And then reports like this one from my colleague and collaborator, Dr. Sharon Fox in New Orleans, in which she did an autopsy series on patients who were hospitalized and died in her health system with COVID-19. All of her patients, this being New Orleans and the demographics reflecting it, all of her patients were Black. And what she noticed here is that in the arteries and the veins of different organs, including the heart and the lungs, you found in the liver, you found clots there. Both arteries and veins, these are small clots and big clots, and microvasculature and macrovasculature. And in my first phone conversation with Dr. Fox, she said the clots just seem to be everywhere we looked. Certainly this is unusual. It's not what we see in other infectious diseases. And so we started to ask ourselves, could we actually be seeing neutrophils and nets forming a role here in clot formation? So we then collected samples from our hospital, and this is Dr. Ray Zhu who did this. He's a junior faculty rheumatologist. And in our first 50 patients in whom we collected samples, this again is in March of last year. So when we didn't know a lot, in Southeast Michigan and Detroit in particular, we're in the throes of the pandemic itself. In our population of patients that we collected samples from, about 40% were white. We had about 60% were black. He measured circulating levels of these neutrophil extracellular traps or nets and found that if you were in the hospital with COVID, you had a level of nets, which is in the left column, in the left squares over there in the beige color. But on the other hand, if you were in the hospital with COVID and you had respiratory failure and were on a mechanical ventilator, your levels of nets, as shown in these orange squares, were considerably higher. And so we asked ourselves, is there something in the blood that might actually be triggering nets to form? And so what Ray then did was take blood from either healthy people or people who were hospitalized with COVID. And in a dish in the lab, we incubated it with healthy neutrophils, and then we looked to measure net formation itself. And here's a result, an example result of what we found. What you see here in this picture, this was a feature of our work in Scientific American. The picture here shows neutrophils in a dish. The blue is actually the polymorph or the polylobular, multilobular nucleus that you see in the neutrophil, marking DNA. And the green that you see here is an enzyme called neutrophil elastase, which we know is spit out of the neutrophil when it starts to form these nets. And you can see that there are these wispy webs of green that start to form here. And this was actually triggered. These are healthy neutrophils that were triggered by serum from patients with COVID-19. In the patients who were in the samples that were triggered from healthy serum, we saw none of this green staining at all. It was just completely blue, normal neutrophils. So there appears to be something in the blood that might be triggering net formation. We hope to be able to figure out what that was. In the meantime, we tried to understand whether these nets could be a biomarker of neutrophil activation, and found that we couldn't really use that to predict which patients were going to get sick. So instead, we looked at a protein called calprotectin. It's also a neutrophil protein that's very stable. It's been used in non-ST elevation MIs as a biomarker, and found that if we measured it on the first day or two of hospitalization, if your calprotectin levels were low, you weren't likely to end up on a mechanical ventilator. But if your calprotectin levels were quite high, you had a much higher likelihood of ending up on a mechanical ventilator at some point in that hospitalization. This isn't a diagnostic tool that's clinically available yet, but based on our data and another study that was published from France, there are now 2 groups that are trying to move this into the clinic so that we might be able to use this in COVID-19 to figure out which patients are at the highest risk so we can dedicate precious resources to them, as well as tailor medical therapy to them as well. So calprotectin is hopefully, we think, coming down the pipe. We then started to think about what might be triggering these blood clots in patients with COVID-19. And what we thought was that this pattern that Dr. Fox had found was very similar to another disease, one called antiphospholipid syndrome. This is a disease in which the body develops antibodies that target phospholipids on the cell membranes and start to trigger clots and inflammation. These patients manifest with arterial clots and venous clots. They can have strokes, PEs, DVTs, MIs, also microvascular thrombosis in places like the kidneys and brain. So we decided to start measuring antiphospholipid antibodies in our patients. What we know from before is that if you take these antiphospholipid antibodies in patients who have that disease and you incubate them with neutrophils, they certainly do form nets and they can trigger thrombosis. And the studies that we did led to a number of different findings. Here's the work that was featured on the cover, and it ended up getting a little more press when Dr. Francis Collins covered it. I know he was a guest speaker in a forum that was organized by the host of this one as well. And then Time Magazine had a feature on some of this work as well. So when we measured this in patients, we found that 50% of the patients who were hospitalized with COVID-19 had an abnormality in one of these antiphospholipid antibodies. And certainly this is much higher than the normal population where the frequency is less than 5%. We also looked carefully at what it meant to have one of these antibodies being abnormal. And we know that it correlated pretty closely with your severity of oxygenation problems. So that's this SpO2, FiO2, where the lower number you have, the worse your oxygenation, higher levels of circulating nets, as well as a higher D-dimer and higher neutrophil and calprotectin levels. So certainly these antiphospholipid antibodies seem to be correlating with the severity of clinical illness. We then took these autoantibodies, we isolated them from the patient's serum. We incubated them with neutrophils. We found that they seemed to trigger net formation again, but that again is all in addition. We didn't know if that actually translated to clot formation. So we took antibodies again, injected mice with these and subjected them to a venous thrombosis model and found that if you injected mice with a control antibody, they got a normal amount of thrombus. But if you took antibodies from COVID-19, these start to trigger really a large amount of clot. And I think this may actually be more illustrative. What you see here on the left is the normal clot, and on right was the COVID-19 injection-related clot. So these antibodies certainly are causing clots that were some of the worst that we've seen in this animal model of disease, and does make us think that perhaps these autoantibodies may be doing a lot of different things. Certainly since then, there have been a lot of reports. This is one from some colleagues of ours, showing that platelets can become activated, and there may be autoantibodies that actually suppress the normal antiviral response, perhaps unleashing more COVID infection in the body itself. And so we've been thinking a lot more about it and reflecting a bit on what other populations may be at risk of this type of thrombosis, where you get clots in many different areas. Sickle cell disease certainly does come to mind. And while we haven't tested it, I want to show you two pieces of data that have already been published by other groups. This is a small cohort of patients that were studied in these large cities that you can see here: Detroit, New York, Chicago, and Boston. 66 patients with sickle cell disease. If they got COVID-19, 75% of them were likely to be hospitalized, which is far higher than the normal population, and 11% of them were likely to die. These patients did manifest with kidney problems, lung infection and clotting, chest pain was frequent, brain fog and confusion were also a problem. And so certainly there's an increased disease burden and susceptibility to it in patients who have sickle cell disease. This more recent report suggested that looked carefully at clotting itself and found that if patients had sickle cell disease, the risk of clotting in them was threefold higher than if you were Black and had no sickle cell disease. So suggesting that in fact, not only are you at higher risk of developing a clot if you're Black, but then if you have sickle cell disease on top of that, your risk is really magnified further. And certainly this is just the beginning of, I think, what will be a very important area of investigation for this group and a large group of investigators who are my colleagues at the National Heart, Lung, Blood Institute who are focused on sickle cell disease and thrombosis risk. And so we hope to be able to learn more and start to develop more therapies. In the meantime, we started thinking ourselves about clinical trials and what we might be able to do to help. And we focused on a drug here called dipyridamole. We started this clinical trial, and I say it says 80 patients over there, but it's actually 100 who were randomized in a placebo-controlled manner to receive either dipyridamole or placebo. Dipyridamole is an old drug. Many of you will remember this. I used this last when I was a medical resident. It's an antiplatelet agent that was used in combination with aspirin to try and prevent recurrent stroke. It's given by mouth, pretty well tolerated. And what we found before in some of our work is that it suppresses immune hyperactivation. We've known that it blocks platelet activation as well. It actually triggers this type 1 interferon response, which is the physiologic antiviral response that's important and also suppressed normally in COVID. And so we think that this may actually have a number of different ways this drug could benefit patients. Most importantly for me was the ability to scale this. It's an accessible drug, it's generic, it's safe and tried in 20,000 patients in clinical trials already. It's inexpensive to the extent that it costs about 50 cents for a day. And so we think that we can scale this pretty easily. Globally, it's even less expensive than that. I think in India, where I grew up, this would be 1 cent a day for a treatment. So quite accessible to a lot of people. And we think drugs like this, repurposing drugs like this may be a way to be able to start spreading treatment in a more equitable manner. So I'll stop here and just summarize that there's excessive thromboinflammation in acute COVID. There are predisposing risk factors to consider. Clinical trials are important, especially targeting both the combination of inflammation and coagulation to try and move the needle in this disease itself. And then looking to a future with this post-acute sequelae of COVID, we need to think about how autoimmune and clotting risk will be examined in the future. Do these persist with time or do they go away? Because I think it will inform a lot of other vascular disease that and other organ systems that may be affected by COVID in the acute and then the post-acute phase. I'll stop here and thank you for your time again. I hope that you'll be able to get some feedback and happy to answer and field any questions that may come up in the Q&A session next. Thank you again.
Thank you so much, Dr. Canty. You have certainly thrown out some very provocative thoughts. I'm sure we're going to have questions waiting for you during the question and answer period. We are now going to move to our last speaker in this session. His name is Dr. Robert Ferrangi, and he is the Chief of the Division of Pulmonary and Critical Care Medicine, Program Director, Pulmonary and Critical Care Medicine at SUNY Downstate. And he is one of our frontline workers, having been very involved in delivering care in the community during this pandemic. Without further ado, Dr. Ferrangi.
Thank you. And I want to thank the organizers, especially Dr. Straker, who did a lot of work putting this all together, Dr. Maxey, Dr. Salafu, and I'm very honored to speak to the group about this topic. Before I jump into talking about COVID-19, I'm going to start with our experience with some other severe respiratory viruses and the long-term sequelae of infection with them. Many of you have heard of MERS and SARS. SARS is the original severe acute respiratory syndrome coronavirus, occurred about 20 years ago. And MERS was about 10 years ago, I think, Middle East respiratory syndrome. Both of these cause ARDS-like picture, just like you see with COVID-19, severe pneumonia. And interestingly, about 30% of the people affected with these viruses develop persistent lung abnormalities after their acute illness. Many of these were mild, but for some of them, they were left with persistent defects in diffusion in the lungs. The lungs' job is to absorb oxygen, and so they were less able to do that. One researcher from China looked at serial CTs and showed that 38% had persistent CT abnormalities after 12 months. And after developing SARS, but after 12 months, it typically only involved a small portion of the lung. And here's an important point. Pulmonary symptoms are frequently out of proportion to PFT testing. PFT is pulmonary function test testing. So they can't be explained by the breathing test, which suggests that other things like muscle weakness could be contributing to symptoms of dyspnea. Now, I'm sure we've heard this term over and over again, long haul COVID. It's persistent symptoms after the 4 weeks of illness. Subacute is 4 to 12 weeks, and chronic is 12 weeks. What are the most common symptoms? Dyspnea, fatigue, exercise intolerance, cough. And addressing these issues is really going to require a multidisciplinary approach with pulmonologists, cardiologists, physiotherapists, and even psychotherapists working together to address these issues in our patients. Now, a lot of what we have come to know about long haul COVID or persistent symptoms beyond 12 weeks comes from observational studies. And we have to realize this is the first data. So some of this is still in evolution. And we need further studies to confirm these results and to gain more information on this syndrome. But this was a very interesting observational studies. 38 hospitals in Michigan, and they evaluated 1,250 patients discharged alive after 60 days from COVID-19 infection. Now, the vast majority of these patients didn't participate in this phone survey. Only 32% did. So you have some selection bias. That's why we need further studies. But of those patients that did participate, 32% of them reported persistent symptoms, dyspnea, cough. So it was similar to what we saw with MERS and SARS coronavirus 1. There's a significant proportion of patients that have persistent pulmonary symptoms after infection. Now, a single center Italian study found that 87% of the 143 patients discharged from the hospital had symptoms persisting after 60 days, fatigue, dyspnea, joint pain, chest pain. Again, that's a single center study, more subject to bias, but it at least gives us some information. Now, how do I know who's at risk for developing long-haul COVID-19? Some of this could be the severity of illness. If you were admitted to an ICU, or particularly if you were put on a ventilator. Think about it. If you've taken a flight across country and you're stuck in your chair for 6 hours, by the time you arrive back in New York or wherever, you're hurting. Your muscles are kind of tight. Now imagine that occurs for weeks and weeks, because that's essentially what happens to a patient intubated with COVID-19. They're often immobilized, and so they can develop severe muscular weakness. So severity of illness can be one risk factor. Pre-existing respiratory disease like COPD or asthma, this is a big factor, one that surprised us. Increased body mass index. Because prior studies had shown that obesity was actually protective in many forms of ARDS, but that wasn't the case with COVID-19. They get it worse. Older age, there are several studies that suggest Black and Asian race are more at risk for this syndrome. And women have an increased risk of developing anxiety and depression after COVID infection. Now, Huang et al. In a study in China looked at people who recovered from COVID-19 from their hospital. And 25% of those they tested at 6 months had reduced 6-minute walking test. Now, they didn't test before and after, but these individuals were below the lower limit of normal for their age. So that's a pretty significant number. Here's a hard piece of data. Almost 7% of patients in another study still needed oxygen or CPAP 6 months after recovering from hospitalization. That's a lot. A Spanish study looking at people who got tracheostomies to maintain a chronic airway found that 52% of them, after getting their tracheostomy, were still ventilator dependent a month later, showing the devastating impact of this long-term COVID syndrome. 50% of individuals still had CT abnormalities. Most of these were ground glass, just a little hazy infiltrate on CAT scan at 6 months. But many patients developed fibrotic changes. We had a patient here at Downstate. We ended up transferring because her fibrosis was so bad she needed a lung transplant, and she received one. As we talked about so eloquently in the prior talk, COVID-19 creates a unique predisposition to clots. 25 to 30% of COVID-19 patients clotting compared to a much lower number, 1 to 10% in other critically ill populations. And in the Italian study that I referenced before, 32% had long-term symptoms, 1 or 2 symptoms, and 55% of subjects had 3 or more symptoms of long-haul COVID. Now, one of the things we're trying to do in the unit is restore you to health. One part of that is getting you back to life, getting you back to work. But only 46% of 120 patients admitted to the ICU in this one study returned to work at 110 days. And the number was 77% returned to work if they were admitted to the general ward. So those that were severe tended not to get back to work. Another study found similar findings. And again, as I mentioned before, Black and Asians had reported more long-haul COVID symptoms than their white counterparts. and post-traumatic stress disorder, anxiety, and depression were highly prevalent in survivors of COVID-19 pneumonia. Now, what about pulmonary function measures post-COVID-19? So this was a study done in Mexico looking at 186 PCR-confirmed COVID subjects at a hospital in the Yucatan Peninsula. And they divided the group into mild, they didn't need oxygen, they didn't need hospital admission. Moderate, they were ambulatory, but they did require some form of supplemental oxygen, but not high level, less than 5 liters. And then severe, they were hospitalized and they required high level of oxygen, but they weren't intubated. They didn't have invasive mechanical ventilation. And they followed these individuals with PFTs at 30 days, 90 days, and also with questionnaires. And one of the take-home points from this study is, who do I screen for long-haul COVID pulmonary consequences? And what this study showed is if the patient that you're seeing has shortness of breath, dyspnea, that's a person who's likely to have PFT abnormalities. So when they broke it down into people that with dyspnea or without, the ones with dyspnea had impairment of their breathing test measures, less ability to walk. You see their 6-minute walk test distance was significantly reduced, and their index of dyspnea, their shortness of breath index, was significantly higher. So if you have someone presenting with dyspnea, that's someone that needs further evaluation. Interestingly, the severity of the disease, at least in this study, as opposed to some other studies, which we mentioned previously, didn't predict who was going to have the breathing test abnormalities or the 6-minute walk abnormalities. If you look at this data, it's not significantly different between the mild, moderate, and severe cohorts. So what really mattered at 30 and 90 days was the patient dyspnea at that time point. Those were the people that were likely to have the breathing test abnormalities and the impairment in their walking ability. Similarly, fatigue was also not a sign or a symptom of or a predictor of who was going to have breathing test abnormalities or abnormalities on their 6-minute walk test. So those with dyspnea had breathing test changes that could explain their symptoms. And the disease severity, at least in this study, that's why we need more studies. We have to see if these findings can be affirmed. The disease severity in this study did not predict who was going to have the long-term changes. And nor did fatigue as a symptom predict who was going to have breathing test abnormalities and 6-minute walk abnormalities. Now, one of the last studies I'll go over is this study from Italy, which also looked at breathing test in survivors of COVID. This was a fairly large one, 767 patients that were hospitalized. They 64% refused to participate, and 4.6% died during follow-up, but they ended up having 238 patients that they could evaluate. Again, this is not perfect. You would rather have all the COVID patients, because then you know that there's no selection bias. But this is the best data that we have. That's why, again, we need further study in the future. So they wanted to identify risk factors associated with breathing test abnormalities, or DLCO is a measure of gas absorption. It's called the diffusing capacity for carbon monoxide. Carbon monoxide is a gas. How well can your lungs absorb carbon monoxide? Because they're going to need to absorb oxygen. And when you looked at it, the factors that were most associated with the abnormal ability to absorb a gas, the DLCO, were female sex, chronic kidney disease, ICU admission, so in this case, more severe, did correlate with worse abnormalities, or COPD disease state. Those were the people that had severe abnormalities in their diffusing capacity. If you're less than 60%, that's considered very significant. Now, what about the breathing test abnormalities? That was a little different. The only thing that really seemed to correlate there was COPD. If you had COPD, you were more likely to have functional impairment after COVID. Age, the older you were, the more likely, and ICU admission again. those were the ones that were corresponded to the functional impairment. So in summary, COVID-19 frequently leaves patients with persistent symptoms, pulmonary symptoms. And interestingly, one study, probably the best study, the Michigan study, showed it was comparable to what we had seen with severe viral pneumonia from MERS and SARS, around 30%. Disease severity, racial factors, and pre-existing respiratory disease do increase the risk of long haul COVID. And long haul COVID matters because it has important effects on long-term health and the patient's psychosocial status. Remember, I showed you that data that the majority of the people with the severe disease had not returned to work due to the long haul symptoms that they were experiencing. And certainly that can have important socioeconomic as well as psychological impact for the patient. And further research is needed to address the diagnosis and management of long haul COVID-19. This is a disease really in its infancy, only been around about a year, and we really need to know more about it. And lastly, I'm just going to end on this really lovely picture of a tree. And when I think of a lung, I think of trees. And imagine, just like you have an airway, the trees have a trunk and branches, and their job is to conduct materials back and forth from the business side of the tree, which are the leaves. That's the part that absorbs light from the sun, just like your alveoli absorb oxygen from the air to give you energy. So unfortunately in COVID, imagine a tree stripped bare of its leaves. And then this is what a patient has to try to live with without the ability to absorb what you need in order to have the energy to live your life. And on that, I'll end.
Thank you so much, Dr. Frangi. And I now invite all of our panelists to participate in our question and answer period. I'm going to ask Dr. Canty to lead off with a response to a question regarding the connection between the clotting and the vaccines.
Thanks, Dr. Stevens, and to the person who asked that question. I think it's quite important to note that the complications of clotting that we're seeing with the vaccines were with only 2 of the vaccines. These were both the vaccines that were based on adenovirus vectors, and they were quite rare. So it's under 0.5% of people. So it's highly unlikely any of us would ever develop a clot to one of those vaccines, and the protection that's offered by it is actually significantly higher to prevent disease and death from COVID-19. The clots that we're seeing seem to be for a number of reasons, and we know that for some reason the vaccine, that particular type of vaccine, seems to trigger an immune response and then clotting that's related in a number of ways to the antiphospholipid antibodies story that I showed you. So there are neutrophils that are involved, there are platelets that are involved, but this again is extremely rare, and it's rare enough that we've got an international group together who are trying to figure out how do we study these clots that are related to vaccines. And the summary is there just aren't enough patients. Not enough people get these clots for us to be able to study it in a systematic way. And so it certainly has led to some hesitancy for people to receive the vaccine, but I would encourage all of us to make sure that we do get a vaccine. And as I think one of my bosses has said, when asked what type of vaccine should I get, their response was, well, you get the one that you can get first. Whatever one you can get first, that's the one you sign up for. So I think that it's an important area for us to think about. But for most of us in our day-to-day lives, the vaccine-related thrombus is not going to be something that enters our sphere itself.
One thing that I was going to add is that it's very important to be frank and honest with the patients. And I certainly want everyone to be vaccinated. As a critical care physician, I see the worst of the worst, and I don't want to see it anymore. And I haven't seen one immunocompetent, fully vaccinated person admitted to the hospital with COVID pneumonia. I haven't seen one, and I see a lot of patients. So I know this vaccine worked. Nevertheless, if you look at the data, there is a slightly increase, just as there is with other vaccines. Influenza Anything causing inflammation is going to increase clotting risk. But I think we have to speak to our patients and let them know, yes, they're, as with anything, and I'll tell them walking across Flatbush Avenue is a risk. There's no guarantee you're going to get from one side of the block to the other. But if they see that you're taking them seriously and their concerns, I think it actually helps to build the trust that will make it more likely for them to take the vaccine.
I think that's a really important point, Dr. Florentine. I'm really glad you brought up those numbers. So when a patient asks me whether to get a vaccine or not, the two numbers that I quote to them are 0.5%. That's the risk of getting it. That's a very high or an optimistic number for the risk of getting a clot from a vaccine. And then the other number is 75%, meaning that when you get the vaccine, there's a 75% chance that you've reduced your chance of death directly from it. So to me, those numbers speak volumes, and I think that we certainly fixate on the bias of, I think, omission rather than commission. We try not to act because we worry something might happen. But in this case, I think we need to have a bias toward action, and that's really going to be the way to protect ourselves and move forward.
Dr. Alexander, I know that you are not a pediatric cardiologist, but you did talk about athletes and their the potential or the approach that needs to be taken in the evaluation of them post myocarditis and clearance for resumption of athletic or other activity, which is similar to a lot of the conversation and thought processes that parents are going through now as they are debating the safety and wisdom of allowing their children to be immunized, as well as there have been several articles identifying in young adults hesitancy for pursuing vaccination because of concerns around the complications that have been described with the vaccines. Would you please comment on that?
Sure. I mean, there's been a lot in the news with kind of vaccine-related myocarditis, and I think with myocarditis, it's important, how you define it. Clinically, as a cardiologist, I care about myocarditis in the context of left ventricular dysfunction, heart failure, arrhythmias. I think one of the things with these high sensitivity troponins, it certainly allows us to diagnose myocardial infarctions, et cetera, but it means that they can pick up very small degrees of inflammation or myocardial injury that we couldn't before. And so I think that a lot of these instances that in the news have been kind of just that, isolated low-level troponin elevations in the absence of any other clinical evidence of myocarditis. And so I think maybe in parallel to the conversations that we're just having about the risk of thrombosis, I think weighing on the risk of COVID infection and transmission versus this very small risk of a elevation of a troponin value outside of other evidence of significant myocarditis, I would still firmly support getting the vaccination. My wife's a pediatrician, so she has these conversations a lot, and I've asked her about this over the last few weeks, and so I shaped kind of my response based on what she said too.
Thank you to all of our panelists. This has been a very stimulating discussion. Some questions have been answered. There are many more that have been raised, and I look forward to continuing this conversation with you in the future. I am to turn the program over to Dr. Salafu.
Thank you very much. This was an exciting session. I learned a lot. The next person will be Dr. Susan Nicholas. She's a colleague of mine, good friend of the West Coast. It's a great pleasure to introduce her. She's Associate Professor of Medicine and Clinical Hypertension Specialist at UCLA. She is actually one of the very few clinician scientists who has a basic science lab looking at the how we can further the science in diabetes and diabetic kidney disease and how we can find cures to that disease. Bio is in the program, very illustrious bio, so you can connect with the bio and then read more about her. It's a great pleasure for me to introduce her to speak on post-COVID and the kidney, disparities in acute kidney injury and chronic kidney disease. Dr. Nicholas?
Thank you so much, Mauro. It's wonderful to see you. It's been a while. I want to start by just thanking you for the invitation to speak at this very important symposium. I think it's a very much needed symposium. It's really an honor for me to be part of these activities. You know, my colleagues and I were, like you, very troubled by the impact of COVID-19 that we saw in many of our patients. And as clinicians and researchers, we wanted to understand better some of the disparities that we saw around kidney disease and COVID-19 infection. And so we created a COVID-19 registry that allowed us to do some of these, look at some of these relationships. So I'm going to share some of that unpublished data with you today. So for our learning objectives, we will review some of the epidemiology and risk factors that contribute to racial ethnic disparities in SARS-CoV-2 infections and the impact of underlying chronic kidney disease on COVID-19 infections, as well as discuss some of the mechanisms associated with SARS-CoV-related kidney injury. And finally, I'm going to review some of the results that we obtained from our COVID-19 registry. This is our abstract, and I'm happy to share that with the audience. But to begin, you know, when we saw this data that was published as early as May of 2020, it was the first really startling, striking evidence of disparities in COVID-19 rates. And this data from the CDC showed significantly higher rates of non-hospitalized, non-fatal hospitalized, and deaths for Black African Americans, as well as Hispanic Latinos in relation to COVID-19 infections. And by January of this year, as you know, COVID-19 was the leading cause of death in the United States. And when we looked more closely at the breakdown, and this is very recent data from the CDC from this month, it showed the age-adjusted distribution of COVID-19 deaths being higher in Hispanics and non-Hispanic Blacks compared to whites, and their relative distribution of these populations within the US. Now, we've known for quite some time that there are significant disparities around chronic kidney disease, but COVID-19 really served to magnify and exacerbate those COVID-19 disparities on top of already existing racial bias in healthcare. As individuals of color were more likely to not have access to COVID-19 testing, they were more likely to live in high density housing, to be exposed to pollution, and to have a pre-existing condition. And also they were more likely to be described as an essential worker, a distinction that they had never previously been awarded. And so some of the disparities that we're very familiar with around chronic kidney disease are as follows. We know that African Americans constitute 13.4% of the population, and Hispanics are our largest minority population, consisting of 18.5% of the US population. However, these are the two groups that have the highest prevalence of chronic kidney disease, with Black Hispanics, non-Hispanic Blacks having 16% prevalence, and Hispanics having 14% prevalence compared to non-Hispanic whites, which are down to 13%. African Americans also have a 2 to 4-fold greater incidence of kidney failure compared to whites, and they're 3-fold higher risk of progressing to kidney failure, and also at an earlier age. And they also account for 35% of kidney failure patients. And in addition, Hispanics have a higher risk of chronic kidney disease progression compared to whites. And as we learned more about COVID-19 and the reasons for hospitalizations, we found that in this large study from Geisinger, it's a phenome-wide study, they looked at almost 13,000 individuals and about 1,600 of them tested positive. And what they found is that kidney disease, regardless of whether it was acute kidney failure or end-stage kidney disease, really was the leading risk factor for COVID-19 hospitalizations. And if we all remember the spikes that we saw within the first 7 months of the pandemic, there were a significant amount of excess deaths that were associated with these spikes. And Black non-Hispanics accounted for 47% of excess deaths during that time, with Hispanics accounting for 25% of those deaths, compared to whites in the green curves that consisted of about 20%. And this spike in excess deaths actually correlated very well with data obtained from the USRDS, which provides us with information on kidney failure patients. When we look at acute kidney injury, and a number of studies now have been completed looking at that, we observed an increased incidence of acute kidney injury in patients with COVID-19. And the incidence ranged anywhere from about 5% to as high as 81%, depending on the definition that was used for acute kidney injury and also the populations that was studied. But there was this one small study that was done in Louisiana where they identified increased incidence of acute kidney injury in Black patients who had 2 of the APOL1 high-risk alleles. So some of the causes of acute kidney injury are volume depletion, as well as high baseline serum creatinine. About 20% of patients in one cohort had acute kidney injury based on a high baseline creatinine. Typically, what we see is that acute kidney injury will occur within the first week of admission. It's also associated with very high mortality rates. In one study, it was as high as 35% in those patients who needed kidney replacement therapy. And if patients are to recover, about 50% recover within 3 weeks of their diagnosis. And in the past, we always thought that if you developed acute kidney injury, that it would typically go back to the patient's baseline. But what we're finding out now is that acute kidney injury is a significant risk factor for chronic kidney disease down the road, regardless of whether an individual had chronic kidney disease at baseline. In terms of the mechanisms for acute kidney injury, what has been postulated is that, you know, that the lungs are the first exposure to the SARS-CoV-2 virus that binds by the spike protein to the ACE2 receptor. And depending on the level of, excuse me, I'm having a little trouble with this computer. Depending on the level of infection, this can lead to pro-inflammatory mediators as well as coagulopathy and microangiopathy, as well as significant hemodynamic issues from sepsis and acute lung injury and acute respiratory distress syndrome that can lead to kidney medullary hypoxia. All of these mechanisms and others can contribute to the development of acute kidney injury in our patients. And SARS-CoV can enter into the kidney through, again, like this, touching to via the spike protein to the ACE2 receptors that are found within the kidneys. And in conjunction with the TMPRSS2 receptor, this facilitates entry into the kidney cells through endocytosis and then leading to some direct kidney injury. So Carruthers have postulated an intersection between socioeconomics and the susceptibility to COVID-19 infection, in that our vulnerable patients who are persistently exposed to prolonged socioeconomic inequalities, as the population ages, they develop more health comorbidities, and there may be increased expression of ACE2 receptor as well as this TMPRSS2 receptor that has been determined to be have increased virulence for SARS-CoV-2, leading to increased COVID-19 susceptibility and eventually to more severe illness as well as death in several patients. So in our COVID-19 registry, this was created from an established registry, which we call CURE-CKD, that is constituted from electronic health records of over 12 million individuals, with data going from 2006 to 2019. And patients enter into the registry based on a diagnosis of diabetes and or chronic kidney disease and or hypertension, as well as prediabetes. And we've collaborated with our colleagues at Providence St. Joseph Health to create this registry. And from that original registry, it was updated recently. And then this allowed us to create the COVID registry, consisting of individuals who were tested for COVID-19, both positive and negative. And it allowed us to harmonize the data sets from the two institutions and then create this sub-registry within the CURE-CKD registry. So the data within our COVID-19 registry includes data from January to June 30th of 2020. And as you can see here, the Providence St. Joseph Health cohort consisted of 154,000 patients. UCLA Health contributed almost 18,000 patients to the registry. And what we observed, and I've separated the data out into Providence St. Joseph Health and UCLA Health cohorts that could take a better look at this. And what we observed is that the majority of patients within the registry were within the ages of 30 to 79. And in addition, more patients tested positive were male. And in the Providence St. Joseph Health cohort, there was a high proportion of Black African Americans, Asians, as well as Hawaiian Pacific Islanders who tested positive. And when we looked at the UCLA cohort within the registry, similarly, we identified the majority of patients within the ages of 30 to 79. Again, more patients who were positive, were male tested positive. But in our cohort, we had a higher proportion of Black African Americans as well as Asians. And when we look at the underlying diseases, again, diseases that allowed patients to enter into our registry, in the Providence St. Joseph cohort, more patients with chronic kidney disease actually tested negative, whereas in the UCLA cohort, more patients with diabetes, hypertension, as well as chronic kidney disease actually tested positive within the UCLA. In addition, within our UCLA cohort, because we've got direct access to this data set, we're able to do additional analyses. And one of those was to identify patients with acute kidney injury. And because we have longitudinal data on our patients, we can look back to 3 months before COVID testing and 3 months after to see the impact of COVID on acute kidney injury. And we identified that patients who were older, age 80 years and over, had a higher odds of developing acute kidney injury, as well as patients with area deprivation index, high area deprivation index by state. And as you may know, the area deprivation index are data that we identify from census data that includes information on poor housing, education level, as well as income. And so this, in addition to chronic kidney disease, and you can see the odds of developing acute kidney injury for those who had chronic kidney disease, very high at 12.20. Also having diabetes put individuals at risk for developing acute kidney injury. We also looked at the odds for developing severe disease in patients who tested positive. And we found that patients who had chronic kidney disease, diabetes, both of these were those who had the highest risk of developing severe disease if they tested positive. And in logistic regression, both at univariate and multivariate analysis, we see that chronic kidney disease was the one that was consistently had a higher odds. And again, really high numbers. Looking at the data for prediabetes, it's actually lower. And it may give you the impression that, oh, if you're pre-diabetic, maybe you're pretty healthy and you don't have a high odds. But in fact, it's patients who have prediabetes compared to patients who have chronic kidney disease, diabetes, or hypertension. So the pool that the patients are in is actually not a very good pool to begin with. We also looked at the odds of severe COVID disease based on the Charleston Comorbidity Index, and this provides us with a huge array of comorbidities that we can identify. And a number of these baseline diseases also showed a higher odds for severe disease, but myocardial infarction was the one that was consistent at univariate and subsequent multivariate logistic regression. One of the other studies that we looked at within our data is the risk of developing kidney failure, even within that short period of time. So traditionally in clinical trials, we can use an eGFR threshold of 57%. So if an individual reaches a decline of 57% in their eGFR, that equates with doubling of serum creatinine or progression to kidney failure. And typically in a clinical trial, that can take 5 years or longer. A number of studies now have been done looking at retrospective data where if we can identify thresholds of 30%, 40%, or 50%, they have been considered acceptable clinical endpoint surrogates for chronic kidney disease. And so looking at GFR threshold really allows us to assess clinical outcomes over a much shorter period of time. And we did this with the COVID registry. And the data that I show you here are specifically for the 57% eGFR decline, but we got similar data for the other thresholds as well. And what we see here is the median follow-up of 60 days after COVID testing in patients who had COVID, chronic kidney disease on the left 2 bars versus patients who did not have chronic kidney disease. And as you can see, those patients who had chronic kidney disease and were COVID positive had a significantly higher relative risk of achieving a 57% eGFR decline, indicating that these individuals are at significant risk for kidney failure over time. So in conclusion then, we've discussed the fact that racial and ethnic minorities are at greater risk for COVID-19 infections, as well as severe COVID-19 related disease, that chronic kidney disease is a significant risk factor for COVID-19 infections, as well as for developing acute kidney injury. And there's an increased relative risk of long-term kidney failure in patients with underlying chronic kidney disease. So we conclude that if we're able to increase our efforts on screening and early diagnosis and delivery of care to vulnerable patients with underlying chronic kidney disease, we could potentially alleviate some of the racial ethnic disparities that we see in chronic kidney disease, as well as the subsequent impact down the road. So with that, I'd like to end and send it back to you.
Thank you very much for a wonderful talk and the data that you have shared, which is very new to me. This is very nice data. We're looking forward to publications on the data. So stick around for the question and answer session. I now move to Dr. Marie Borum. She had some little connection issues. That's why we couldn't get her on time, but she's available now. Dr. Borum is Professor of Medicine and Chief of the Division of Gastroenterology and Liver Diseases at the George Washington University School of Medicine and Health Sciences. She has published extensively in the area of GI. She has received many awards, and she's really well known in the area of GI diseases. It's a great pleasure of mine to invite her to speak on the topic COVID-19 and the GI system, what we have learned so far during the COVID-19 pandemic. Dr. Boro?
I thank you for inviting me, and I really appreciate the opportunity to talk at this really important conference. Because as the pandemic continues, we learn more and more about the sequela of acute infection and how it's impacting the patients that we see. I have, as you mentioned, I'm from George Washington, and I have a particular interest in looking at issues related to the gastrointestinal tract and hepatobiliary tract and how COVID is involved. For this particular talk, I have no disclosure. For the next few minutes, I want to review these particular issues. I want to look at the gastrointestinal manifestations. I want to review hepatobiliary involvement. I want to talk about a couple of the issues that are related to those people who have pre-existing gastrointestinal or hepatobiliary conditions and what the impact of COVID on them. And I want to share the emerging information about gastrointestinal and hepatobiliary long haul symptoms. One of the things that we all know on this call, and one of the things we all know in our practices, is that COVID infection obviously has a clinical spectrum of diseases, symptoms that range from asymptomatic infection to critical and fatal illness. And while in the beginning of the pandemic, we have been focusing on the respiratory symptoms because those were, of course, causing the most critical illness, causing the ICU bed involvement, causing most fatalities. But as we learned to take better care, as we learned about the disease, as the pandemic continued, we began to recognize, particularly noted throughout this conference, that there are extrapulmonary complications that can occur that are important, that need to be addressed, and those, in fact, include the gastrointestinal and hepatobiliary system. As the pandemic over the past year and a half has gone on, we've come to learn that 1/3 of patients who have COVID infection will have GI complaints. Initially, these symptoms were not systematically reported, so the appreciation of the involvement was clearly underestimated. It was not known that GI system was so involved as it was. It was not appreciated and very often was not recorded. Now, the high incidence of GI manifestations is either directly related to the COVID virus itself or to the critical illness that is caused by the infection. But it behooves many of us in the GI field to recognize that GI manifestations are frequent, they can be critical, and it's important that they're addressed. But as we have learned at GW and some of the other international studies, is that while GI symptoms are apparent, it does not seem to appear to affect mortality. They can be troublesome, they need attention, they need to be treated, but GI symptoms alone do not affect ICU admission rate and do not affect mortality. Morbidity certainly, but not mortality. So let's look at some of the early meta-analysis. This is what we're going to talk about. This is what I just initially addressed. This is where we talked about 1/3 of our patients having GI manifestations, and let's catch up to the meta-analyses. So one of the earliest meta-analyses that came out of China shows that the pooled prevalence rate of GI symptoms was about 17%. And that was before there was a systematic collection of the GI manifestations when people were hospitalized. But in that study, it suggested that about 1/4 of the patients had anorexia, 12% had diarrhea, then there was, of course, nausea, vomiting, and abdominal pain. A subsequent meta-analysis of about 18,000 patients showed that diarrhea was the primary manifestation that people had, with nausea and vomiting occurring at about 6%, and then abdominal pain. What has subsequently come out, and what is so very important for those of us who take care of our patients in the hospital, is that our critically ill patients in the ICU, the ones who have significant pulmonary disorder, have a whole host of GI manifestations, from constipation, diarrhea, to nausea and vomiting, but of course abdominal distension, and abdominal pain. Much of this may be related to just being critically ill in the ICU, but of course, some of it may in fact be directly related to COVID. When we look at hepatobiliary manifestations, the most common abnormality that we will see is elevated liver enzymes. They're typically mild, often less than 5 times normal. Higher values can occur, and one can actually have acute hepatitis from the COVID-19 virus itself. There have been case reports suggesting that. In our hospitalized patients, though, our liver enzymes elevations are much more common and are much higher. There also have been reports of acute cholecystitis, and when the gallbladder has been taken out, they've actually been able to identify COVID viral particles and active virus in the gallbladder, and acute pancreatitis has been reported. So what's so important for those of us who are in the hospital is to recognize that critically ill patients are at a high risk for GI and hepatobiliary complications, whether from COVID or from being critically ill. And then there's a whole host of manifestations that we need to address. The injury in the hospital, your enzymes can be well over 400. Injury can progress to ischemia and to liver failure, at least one case report of that. But as one recovers, as the illness gets better, as one improves from a pulmonary standpoint, very often the liver enzymes will get better also. The acute cholecystitis that occurs is mostly acalculous, and the acute pancreatitis is just not well understood. Ileus and feeding intolerance, that happens very often to those people who are in the ICU. It seems to be a little bit more for those people who have COVID and are in the ICU. Colonic pseudo-obstruction has been described in several cohorts to a greater degree than those people who are just in the ICU for non-COVID related issues. And the mesenteric ischemia that occurs, we believe, has some relationship potentially to the thromboembolic phenomenon that has been noted elsewhere. We too believe that the GI system is affected because the virus enters through the angiotensin converting enzyme receptor and can cause direct damage to the GI system. We have been able to detect from multiple GI sites through PCR the SARS-CoV-2 virus. But we're not quite sure the multiple factors that are involved with GI manifestations. So for instance, we very often will see a virus shed in the stool. We're not quite sure if there's active replication or if this is just virus that is entered through a respiratory swallowing of secretions. But we do know that there can be direct effects and there may be also indirect infection. What became so important to us, and one of the things that was particularly interesting for us at GW and for those of us who are involved in patients who have underlying immune dysregulation, was how these people are actually going to fare during the height of the pandemic. So you can imagine the inflammatory bowel disease community was particularly concerned because we know that they have immune dysregulation. We know that they are on immune medications to manage their disease. And so the questions that came up were they at increased risk for the virus? If they got the virus, were they at increased risk for greater complications? And what should we do about their medication? Well, it turns out through our national database, we have found that inflammatory bowel disease patients were not at increased risk for acquiring the virus, that having their immune suppression medicine or their biologic medication did not increase their risk beyond the general population about whether they would get complications of the disease. And in fact, continuation of all their therapy was recommended. When their immunosuppressants or the biologics were discontinued, either self-discontinued or discontinued earlier in the pandemic because we weren't quite sure how to manage the patient, we found that actually resulted in disease relapse. So it's recommended that our patients stay on those medications. And similarly, as I talk about two other major issues that we take care of in the GI community of people who have immune dysregulation, is people who have autoimmune hepatitis. they too are not at increased risk for of acquisition of the disease more than the general population. They're not at increased risk for more severe disease, and decreasing their immunosuppression medication, again, was not associated with improved outcomes. So again, we needed to maintain them on their medications. But what happens to our liver transplant recipients? These are the patients that kept us most nervous. We were particularly nervous about how our liver transplant patients would fare. And in fact, it turns out they did better than we initially anticipated. The immunosuppression had to be continued without adjustment, and they did not have a greater risk of complications than the general population. But if indeed they got infected and they became critically ill, any adjustment of medications in them or in our autoimmune hepatitis patients or in our IBD patients was certainly individualized. But from the beginning and throughout this pandemic and ongoing, we do not and should not discontinue the medications or change them. But what about the long haul symptoms? What about the symptoms that we're trying to focus on today? What about those people who get past their acute infection? This is a slide that very often talks about the typical symptoms that we focus on. And as you can see on the slide, GI is not on here. We do not have gastrointestinal disease looked at in the same way as others because perhaps their disease is not as systematically followed because their symptoms are not as severe as the heart, the lung, the brain, the kidney, or thromboembolic phenomenon. But I would like to mention that, in fact, it's important to understand that the GI system and the liver system are involved with some long haul symptoms. They are symptoms that we want to address just like we address the others. They may impact more on the quality of life, but in fact, while we're trying to get over COVID infection and our COVID-19 survivors, it's important that we address our GI disorders and our liver disease. In fact, when we look at viral shedding, we find that viral fecal shedding has been documented following acute infection. We find that you can have virus in our feces even after you have negative respiratory samples. We have detected full virus. We have detected viral particles. The question is, are those viruses actively replicating in the GI tract? We have differing opinions on that in the GI community, but it just raises the idea and reminds us that we have to continue to look at that because GI manifestations or prolonged GI manifestations may actually occur after the acute infection is gone. And in fact, the other area of recent research interest is how the COVID-19 virus actually alters gut microbiome, because that in fact will impact upon gut functioning and symptoms. So there are current studies at our institution and at many other institutions and sponsored by the NIH to look at the long-term consequences of COVID in the GI tract and in the hepatobiliary system. So there is some emerging data. So let me share with you the few studies that have come out that have specifically addressed the gastrointestinal system and hepatobiliary system. There was one study that came out of the VA. They looked at the VA system. They looked at over 74,000 patients. They had 6-month post-acute sequelae evaluation. And we all know that people who have had COVID-19 and have sequelae have a greater, and long-term sequelae have a greater use of health resources, have a higher risk of death. They have extra pulmonary manifestations, and the abnormalities include all of the ones that we talked about today: respiratory, neurologic, mental health, metabolic, cardiovascular, renal, and in fact, the GI system. And the post-acute GI sequelae that were actually talked about include esophageal disorders, including swallowing disorders, abdominal pain, increased liver enzymes. But it turns out that these symptoms from the GI tract weren't as systematically evaluated, similar to in the early pandemic as they're being evaluated now. So what they also did in this study was to look at the GI medications that people are newly taking after their COVID infection. And there are a whole host of additional medications that people are taking specifically aimed at the GI tract after they have gotten over the acute COVID infection. Laxatives, anti-nausea medicines, antihistamines, antacids, antidiarrheals, all of which tell us that we need to pay greater attention, we in the GI community need to pay greater attention to the post-acute sequelae. There was another study that looked at a 3-month recovery. GI complaints occurred in 20% of patients. But what is interesting is one of the only studies that have looked at a non-hospitalized cohort, those people who got COVID infection, got over the acute infection and did not have to come to the hospital, did not have persistent GI symptoms. So while GI tract and the hepatobiliary tract are involved and can be involved in long-term and persistent symptoms, it's those people who have been most ill, those people who are critically ill, seem to have the longest of the GI complaints and symptoms. When we have someone after their acute illness that comes to us, and we have, like many institutions have, long haul clinics, we have noticed that there are abnormal liver enzymes. And those who have abnormal liver enzymes after when they're coming in to see us as an outpatient typically have been those people who have been the most ill in the hospital, and typically are the people having a slower recovery from their acute infection. As the infection and the recovery gets better, as many of the other symptoms improve, the liver enzymes tend to get better, but there's a slower recovery for those people who have been the most ill. So it tells us to look. It tells us to look more. It tells us to look frequently and systematically. When you look at the radiology studies who are doing MRs to look at the lungs, and they happen to look elsewhere, they did find that there were issues related to the liver that were not there pre-COVID infection. So continued studies are necessary to determine the extent of post-COVID sequelae in the GI system, in the liver, and we continue to watch this so that we can determine what our long-term health concerns are and whether there's differential outcomes depending upon our population. I have a whole host of references that are available. So as we conclude, understand that the GI system, the liver, have significant complications. Up to 1/3 of patients can have symptoms. The most common symptom in the GI tract is diarrhea. The most common symptom in the hepatobiliary system are elevated liver enzymes, but there are a range of symptoms that can occur. Pre-existing gastrointestinal and hepatic disorders that are immune dysregulation diseases are not at increased risk, are not at, compared to the general population, do not have an increased risk for worsening or more complications compared to the general population, and we do not need to change their immunosuppression or their biologic therapy. But I continue, like everybody else here, to look at the long haul symptoms, to look at the long haul symptoms in the GI hepatobiliary tract, because if we don't watch for it, if we don't look for it, if we don't systematically ask for it, we will miss it, and our patients will continue to have morbidity that we may be able to address. So indeed, more study is necessary, and many of us are doing that. And I thank you. I have a host of references, if people are interested, that are available. Thank you.
Wow, thank you very much for this tour de force. This is very good. So now we're open to questions for this session. Dr. Borum and Dr. Nicholas. I have a question in the chat. I'm going to read the question and then Dr. Borum would respond. The question has to do with whether patients with pre-existing GI diseases have higher risk for COVID and long COVID syndrome. That is, if somebody has pre-existing condition, GI condition, does it increase the risk for COVID-related infections and long COVID?
So the conditions that have been most studied and the most evaluated are the ones that we've been able to have national database on. So the pre-existing GI conditions include something like inflammatory bowel disease, ulcerative colitis, Crohn's disease, microscopic colitis. Those are the ones that we've been able to have a national registry for. And we have not found that people who have IBD have an increased risk for getting the disease. We do not find that they have an increased risk for having greater complications, and we did not change the medications. The newest area of research has actually been looking at the gut microbiome, because they're trying to figure out how that may actually impact upon something like irritable bowel syndrome. We don't have the data yet to look at our IBS patients and whether having COVID and a change in their microbiome actually changes their symptoms. But from what we see with our IBD patients, we haven't found that even after they've gotten over acute COVID, that they have had more issues with long-term sequelae than others.
Thank you for that response. Question for Dr. Nicholas. It has to do with patients who have recovered from COVID and they are discharged home. Have you seen any increased risk for persistence of the AKI, long term, like 1 or 2 months later?
So the interesting thing about acute kidney injury is it's typically an in-hospital diagnosis, right? Based on the KDIGO guidelines, because you need labs within 48 hours or 7 days of whatever the event is. And so in our registry, we looked really only at patients who were in the hospital, and those were the patients that were part of the registry. Now we have the opportunity and the ability to continue to look at patients subsequent to June 30th, which is the end of the period for the registry. We're in the process right now of refreshing our registry through December 31st of 2020, and also through June of this year. So that's a question that we can potentially look at to see. For example, I showed you the 57% threshold decline. We can take a look at patients who entered the registry and over a longer period of time, how they fared. But we haven't done that to date. And those are studies that we certainly can look at.
So the follow-up question to that would be, if I were a patient, the question that comes to my mind is, would I be on dialysis if I develop AKI, acute kidney injury in the hospital? That is the biggest question in my mind.
Yeah.
So what is your answer?
Yeah, so in the hospital, we can identify patients who required dialysis. But unfortunately, within our registry, we don't have access to patients who are on dialysis outside of the hospital, who are in DaVita or Casinas or other dialysis institutions. So we are unable to look at patients long-term to see what happens to those individuals. One of the things that we can do eventually, we're in the process of linking to USRDS and National Death Index, so we can potentially track those patients over time. In terms of the identification of the cause of death or kidney failure, then that's something else that we have to look at in more detail.
Thank you very much for the response. And back to Dr. Boro. I was very worried about the persistence of the LFTs, the liver function test, the AST and the ALT abnormalities. Is it something that we should worry about long-term? Is it something that would resolve over time? Or is it going to be something that will result in the chronic hepatitis long-term and result into decreased quality of life and the like?
Sure. There are two parts to that question. We found that people who are hospitalized and have severe disease in the ICU have the greatest risk of having significant elevations in their liver enzymes and may in fact have liver injury that can persist for a bit. But as the patient recovers from the other multi-system issues, we find that those liver enzymes eventually and typically decrease. In severe acute multi-system disease, where we have significant complications in multiple organs, that certainly can be part of the picture with liver disease, but that has not been a defining issue for many people. For people who have low level liver enzymes, less than 5 times normal, that are seen as outpatients, those typically resolve over time.
That is good news. Thank you. That is really good news. Thank you very much. I think we are at the end of the symposium. We are now going to have closing remarks. But first, I would like to invite the planning committee to be ready for comments, few comments before we close. I would like to showcase Dr. Pamela Straker. Behind every success story, there is an engine behind it. And the engine is Pamela Straker, PhD. She's been amazing in trying to coordinate all the activities with the speakers and the staff to make sure that this day is very possible. So thank you very much, Pam. We are very lucky to have you. My own comments have to do with a few of the follow-ups. There will be a link. I've already posted the link, the website where you can access the materials for the symposium, that is the lectures, the PowerPoint presentations. We are planning a manuscript rapid publication very soon, hopefully in the next 2 months. So speakers, be ready. I'll be following up with you to make sure that we have those manuscripts out. It's likely going to be a book format, but if not, it's going to be a supplement in the journal, whichever will give us a rapid publication, because this is a hot topic. We need to get the word out so that we can educate the public and also create the awareness that this issue is a serious issue. The other thing I want to mention is that this is the beginning. So we named it the first symposium. That means that there will be a second symposium. So next year, be on the alert. We would call you again to update your talks. And hopefully if we have more than half a day, we might expand it to maybe 2 half days, maybe Friday and Saturday, but depending on what we get, what the data shows in the subsequent year. So be on the alert and look out for that. The last thing I want to mention is the speakers. Thank you very much for wonderful contributions. Everything went so smoothly. We thought we were going to have IT problems, connectivity issues, but so far everything just went so smooth. We are so grateful for that. Your time and everything will be rewarded by you having a hard copy supplement or book on your desk. All right, we promise you that, and we're going to make that happen. So thank you to all of you for the wonderful contributions. Dr. Maxey.
Yes, thank you so much, Dr. Salafu. You were our main coordinator. I'd like to give thanks to our moderators, Dr. Ivan Walks and Dr. Barbara Neighbor-Stevens, as well as yourself, and all of our erudite, astute speakers with this groundbreaking information. This was so great. There was a question that people wanted to know, where will the Cliff Notes be for lay people? Well, we're going to have a session this Sunday in the Black Health Trust. Dr. Salafu, Dr. Stevens, and Dr. Walks and myself are going to review some of this data that was presented, as well as Dr. Gary Dennis. That can be found at blackhealthtrust.org. You can register or you can stream it live. It will be 12 noon Pacific, 3 o'clock Eastern on this Sunday, and every Sunday we will be doing this. So thank you, all of our speakers and our listening audience. Thanks for everything. And Miss Dr. Straker, thank you so much. You're the glue of all.
Thank you, Dr. Maxey. Dr. Neighbor-Stevens, any final comments before we close?
I just want to thank all of our panelists that participated and brought us cutting edge information. And I want to thank our audience for joining us today.
Thank you. Dr. Walks?
I just want to thank everyone. My favorite comment in the chat was from someone who said that they didn't have medical training, but were able to follow the presentations. And that's so important. Kudos to all the presenters who are able to speak to all of us. So thanks so much. This is so important.
All right, so it is 4 o'clock on the dot. I think our mission is accomplished. We now close and hope to see you soon. Final word is to the CME office. Thank you very much for the coordination. And we are so happy and lucky to have you and being able to do what you do. So thank you to all of you.